I just
All
hit the
right.
record button. Can people hear it?
Yes.
Yes.
And
Welcome,
Linnea Lindsay
everyone.
is here.
Welcome, Linnea. Welcome to the March 20th, 2025 Health Evidence Review Commission meeting. Let's go ahead and start with roll call, and then I'll get the opening slides.
Great. This is Daphne. Devin Consagra,
Here.
Mark Buckholz, Stacy Geisler,
Here.
Max Kaiser,
Here.
Lisa Kuzis,
Here.
Linnea Lindsay,
Present.
Lawrence Lyon,
Dr. Lyon, are you up?
Yeah, can you hear me?
Oh, see you.
yeah, I can hear you now. Chris Pinzon,
Here.
Katie Shabel,
Here.
and Leslie Sutton.
Doesn't look like
Is
we
that-
have this.
Yeah, I don't know if we're expecting Mark and Leslie,
Okay.
but we do have a quorum.
Great. Liz, could you start the opening slides?
Yes.
So while she brings that up, welcome again, Health Evidence Review Commission meeting. We are here in support of the Oregon Health Authority's goal to eliminate health inequity by 2030. Our purpose today is to make coverage recommendations and decisions for the Oregon Health Plan. These decisions will affect over 1 million OHP members, as well as their families, caregivers, and providers. And as a reminder, no decisions will be made today about individual care. These are policy level decisions. We also have a couple people registered to offer public comment on our topic of cervicogenic headaches a little later. So we welcome them. We'll unmute them when the time comes. Our decisions are not final until voted on by this group, and then will be implemented at later dates, which will be specified. Some of them will be implemented in October, others will wait till January of 2027. And in general, our considerations here include an assessment of the benefits and harms of a particular health service, as shown by the medical evidence and expert opinion and guidelines and so forth, as well as patient values and preferences, stewardship of public resources, and the nature of our delivery system. Things like, is there a provider in all parts of the state? Members, if you could stay on camera as much as possible and be attentive. If you go off camera, just please let Daphne know that you're either stepping away and not able to participate in votes, or that you're still there but off camera for whatever reason. Our votes again will be by roll call, as we've been doing the last couple of meetings. And we'd ask you to speak up or raise your hand rather than using the chat. It's difficult to monitor multiple information channels, so just go ahead and speak up if you have something to say at an appropriate time. For those offering testimony, if you haven't already, please make sure your Zoom name matches your registration name. You can do that by right-clicking on your icon or picture. And other participants who are not testifying, you can use the Q&A feature to ask questions, and our staff will address them as we are able. The chat and Q&A are part of the public record and may be released by public records request. And this meeting is recorded and will be posted online on our meetings page. Next slide. And if you have questions you can't address during the meeting or don't address, please follow up with us. Email address there, herc.info@oha.oregon.gov. And with that, we can get the conflict of interest and the minutes approval.
Okay, so conflict of interest declaration.
Yeah, just an opportunity for anyone who has conflicts with regard to any topic on today's agenda. Anybody want to make any declarations? It's like nothing.
It's a little tricky because the BBBS covers a lot of ground.
It does cover a lot of ground, so if something comes up that you weren't expecting, please just speak up. And thank you also to all of you who filled out your conflict of interest declarations. I think everybody did. Most of those were no change, but we'll be reviewing those and maybe in touch in the coming weeks.
All right, and then approval of minutes from the last meeting. Any comments or concerns about the minutes? And if not, do we have to do the kind of formal vote thing? Okay, so I think those of you online can approve the minutes.
I motion to
chat.
approve the minutes.
Yes,
Second.
Would you,
where,
we will be calling the roll. Go ahead, Larry.
can you, put the minutes up? Where are the minutes?
Oh, they were in the
They're in the
meeting.
packet.
Oh, that was for,
The minutes from the last meeting.
For the prior meeting, yeah, they're towards the beginning of the packet. We don't usually scroll them on the screen because
oh, okay,
they
because
go
I
by
saw,
very fast.
Yeah, you would have had to look at them.
I looked at the meeting materials, but that was for the VBBS. Are they in that packet?
Jason, you want to tell them there's one packet?
Yeah, there's one packet and it was posted on both meetings and they were identical. So if you saw one, you saw the other.
Oh, okay.
So there are minutes from the HERC and the VBBS from January, as well as EBGS from February, and our oral health advisory panel from February.
Oh.
And
Okay.
Dr. Lyon, I'll track down the
This
page
is-
number for you.
Okay, thank you.
Okay, and then so we'll do a roll call vote for that.
Did we get a motion in a second?
Yeah, I think we did.
All right, Jessica, would you call the roll? You need me to?
I sure can.
Go ahead.
And so I'm calling Devin last, correct?
Yes.
Okay. Mark Buckles,
Approve.
Stacy Geisler,
Approve.
Ben Hoffman. Oh, he's not here. Max Kaiser,
Aye.
Lisa Kouzes,
Aye.
Linnea Lindsay,
Approve.
Lawrence Lyon,
I am looking at them from the other website, so I got them, so I'm going to approve.
okay, Chris Pinzon,
Approve.
Katie Shable,
Approve.
and Leslie Sutton.
Not here.
Not here. Okay, so not here, making a note of that. And Devin Consagara.
Yes, approved.
Motion passes.
All right, great. All right, directors. report.
Yeah, okay, I have a couple updates for you. First of all, looking forward to seeing many of you at our retreat on April 18th. We are still nailing down the location. We had hoped to have it here, but this building is closed on Fridays. So we'll be having it in Portland, either at the Portland State Office Building or at the 5 Oak Building. Still trying to figure out what has the best AV setup for those attending remotely. I will get you parking information and all the details by email, and we'll be posting that on our website if anybody's wants to attend from the public. That will be a public meeting, although we won't vote on anything. We'll have a federal update from our Health Policy and Analytics Director. We'll have some information from our Health Analytics Division in answer to some of the questions we've heard from this group about data to inform our decisions like claims data and so forth. And we'll also be really diving into our decision methodology, how we review evidence and other sources of information, and how we incorporate those into our decision process. So looking forward to seeing many of you at that event. We also have a legislative update. There are a number of bills in the legislature related to our work. There's one actually starting in about 90 minutes on biomarker testing, which would require broad coverage of biomarker testing in the Oregon Health Plan. There's another one that had a hearing the other day on continuous glucose monitors, which would expand the coverage you all approved a year or so ago to include people with using any type of insulin or who have, I believe it's some degree of hypoglycemia. And the third one was related to coronary artery calcium scoring, which is a imaging technique that screens people for coronary artery disease. That one's in the Senate. In addition to all of those, which are more the kind of thing we see every session, there are two bills up for hearing next Thursday, March 27th, unless anything changes. And those would actually affect the statute that governs our work. One of them is introduced by the state, and one was by the governor's office at the request of the governor, and the other was introduced by some other interested parties. And basically to align with the benefit update project and address the end of our 1115 waiver. So we'll stay tuned for what happens there, but that is going on.
I mean, are would those have any appreciable impact on?
So the one coming from the governor's office, we've been working with the governor's office on that. There will be an amendment posted soon. And that will align with what we've been talking about. The other bill, I believe, creates a task force to study the best solution to the situation and would not involve changes to our statute. So we would still be doing the same thing we are today until something else happens. So everything is very dynamic, as is often the case in the legislature.
So I don't understand the difference between them.
Well, the task force wouldn't actually change our governing statute. They would just create a task force to talk about changing the statute. So we would be operating under current law. However, our federal waiver would end in January 2027, and we as an agency would need to decide what to do if that bill were to pass. But again, either bill could be amended. I would watch rather than, expect it to end up exactly as what you see on the website now. And I can tell you that there will be an amendment to the first one because it just currently says there. It's also a study bill at this point, but that should be being updated. Any other questions about legislation?
Hey, Jason, can you hear me?
Yes.
This is
Yes.
Mark. In regards to the legislation, is this normal for example, biomarkers to go through a legislative approval process rather than a HERC medical approval process?
Yeah, so this happens every session. Usually the bills do not move forward. Often there is a fiscal impact which affects that. But the legislature has the authority to mandate coverage of certain services. They did it last year or the year before last with gender affirming treatment. In other cases, bills have been converted to be HERC shall study whatever service, like we had with Panda Pans a couple years ago. So it just really depends. Ultimately, we serve at the pleasure of the governor, and we follow the law as established by the legislature and signed by the governor. But it's not uncommon to have bills like this be brought forward.
That's a good question. I was kind of curious about the same thing. The number of these is increasing
Yes.
or not.
I would say over the last 10 years, it's increasing somewhat, but there have always been bills.
Yeah. I mean, we've definitely heard about them. I think the gender affirming treatment one is qualitatively different. Than
Yeah, that one's a different deal, yeah.
It is kind of straight into the coronary artery calcium scoring one, that's very specific and
It is very specific.
would seem to be hard to tangle with in a legislative session.
And what we've done as an agency is we've posted testimony summarizing the decision the HERC made. And that's been discussed in the two hearings that I listened to. And legislators, will decide what to make of that along with the other testimony and information there's.
Did they ever HERC testify with these?
We have not been testified. We've been providing written testimony. If requested, I think we'd be available for that, but that hasn't happened to date on this. I wouldn't be surprised if we would testify at the one directly about, changing the nature of our work here.
You said something about the biomarker rule?
We have a letter that was just posted today. Yeah, it's up on the website. It's from Claire Pierce Roble, who is our HPA director, but we assisted, our staff assisted in drafting that. Any other questions?
All right.
Okay, and we have a couple other items. We had a listening session. There were, actually, Daphne, do you want to speak summarizing that? And then we'll talk about OHAP as well. Were you going to summarize the listening session?
Oh,
I
I'm sorry, I'm
can't
not
keep my
prepared.
surprise. You're not
Yeah,
prepared.
I'm not prepared to do that.
I will shoot from there.
Ariel,
I could summarize.
You can do it? Okay,
yeah,
Yeah, so we had
Ariel wrote the report.
Great.
we had a staff listening session in February, and
Page 99.
we heard testimony from several advocates who were requesting consideration for expansion of applied behavioral analysis, or ABA, to a wider variety of conditions. They spoke to, in their experience, how effective it was for a very wide variety of conditions. But their ask of the commission is to look at the evidence for coverage of ABA for people with intellectual disability or developmental disability. Staff received quite a copious dossier of references that we from this group, and we will work on it internally, come up with the best sort of review process, and we'll keep you updated. And then we talked a little bit, kind of gave a public facing version of sort of the Benefit Updates project, got some good feedback. And then we have another listening session planned, Daphne, for
March 31st. I'll throw that in chat. And then a second quarter one will be on April 30th. And we're soliciting topics. We finished soliciting topics for the March, just as soon as the
So Daphne's breaking up. She's saying we're still soliciting topics from people who want to speak at that. We haven't determined what those will be yet. So, and again, we ask members not to attend those. We want to keep those more informal with staff, and we will report the results to you, and any topics that come from that, we will let you know that's where it came from. And again, there's a more detailed summary in your materials.
Great.
And then the oral health meeting in February.
we had a February oral health meeting where we talked about the BP updates for both general oral health as well as for TMJ. No decisions were made in February. We actually met again yesterday, and that group has passed a version of recommendations for the Benefit Updates project for both general oral health and TMJ. There was no way we could turn that around quick enough for you all to see that, so you'll be seeing that in May and be able to vote on that. We also talked about hydroxyapatite medicament, which is kind of like a alternative to fluoride varnish, and the evidence is that it's not effective, and so you'll see that again in May, basically with recommendations for non-coverage. That's just a teaser for what you're going to see in May.
And that is all I have in the director's report.
Oh, the hire.
Oh, the hire, the best news of all, yeah. Why do I always forget this? It's been booked, it's been,
You feel like
happening-
it's snatched out of your
I've
hands.
known about it for a long time, so I'm very pleased to announce we have a new medical director hired to help with the tasks that Ariel has been faithfully performing for many years. She'll be half-time. Her name is Heidi Gullett. She did her residency a number of years ago at OHSU, and since then has worked in academia at Case Western University, also in a federally qualified health center as a physician, and also led the Cuyahoga County public health response during the pandemic, worked with their public health department for many years. Comes highly recommended. The reference were glowing, and her interview was wonderful. She will start April 1st. which is a very auspicious day to start working with her. Both Daphne and Liz started on April 1st, although Liz kicked off the pandemic, so I don't know. I think it was underway before she started. So we're really excited to have Heidi join us. We don't know if she'll be in person for the retreat, but I'm fingers crossed that she will. Otherwise, she'll be online. She'll remain living in Ohio, but excited to have her join.
What's her specialty? Family medicine.
Family medicine.
Wait, sorry. I did not get that. What?
Family medicine
Okay.
and then preventive medicine, public health.
Oh, cool.
Yeah, she also has an MPH from Portland State.
Wow, that's great.
Really excited to get somebody with that much experience and broad experience.
It's good news. That's great for you. Good, okay, public comment?
We do not have any public comments.
Oh,
other
we
than
don't
the,
have the cover.
Cervicogenic headache, which we'll take along with that topic.
Oh, we're not here. All right, well, we can move on to BBBS.
Great. BBBS met this morning, and we did our usual consent agenda. There was no discussion of any of the topics on the consent agenda. They were all approved as in your meeting materials. If anyone has any questions or wants me to talk about any of the particular items, I'm happy to do so.
Page 101, the VBS report starts on.
Yeah, so these are either straightforward coding corrections or some straightforward guideline note corrections. Then we also went on to talk about the April 2025 HCPCS codes. Just as a reminder, CMS is releasing their HCPCS codes on a quarterly basis. There were 5 codes that we needed to find a home for. One was a code for a test for hepatitis C. We recommend that HSD put that on the diagnostic procedures file. Then there were 4 additional codes that had evidence reviews. One was actually a simulation angiogram, which is not directly therapeutic. It's more of a teaching tool. So that was added to excluded services guideline E2 as not a therapeutic intervention. Then we had bronchoscopy using electrical field to destroy a tumor or lesion. That is still quite investigational. There's just been a couple of very small case series. There are a couple of trials that are either currently underway or planned, but it appears to be experimental at this time, so excluded services guideline E2. And then there was a AI software that would use CT scan data to come up with some cardiac volumes and wall mass and other things. Most of our sort of computer manipulation of already acquired radiologic data we don't cover. This also actually doesn't has the evidence is that it's brand new, hasn't really been studied. We're not quite sure how accurate it is. So also excluded services guideline too. And then the last was a bone imaging that bones are best imaged with CT scans, but if a person has an MRI scan, which is usually done to look more at soft tissue, there is ways of manipulating the MRI data to come up with a bone imaging. Again, previously acquired imaging data manipulation is excluded, so that's excluded services guideline E2. Anyone have any questions?
I'm sorry, can you speak up and a little more slowly, please?
Oh, I'm sorry. Yep, I will speak a little louder and a little more slowly.
Thank you.
Okay.
So I have a question about the AI stuff. So, I mean, how do we, so are we approving or not approving the use of AI? I mean, I'm not disagreeing with this. I'm just curious, as new AI technologies come online, is HERC being asked to be the governance structure for the AI? And if so, how do we do that?
We're gonna need to grapple with that as medical codes get released, like, you know, if it's being billed and paid as a healthcare service, we'll need to grapple with, and address that.
That's a whole thing.
Yeah, it'll be a whole
In the
thing.
whole thing. This particular one, luckily, we had a review that was very recent that had looked at it and didn't find, basically, they said that it seemed to be okay, but in future studies, we needed to examine its diagnostic and prognostic utility.
I have a question about this. So I'm this is making me think of just because you can do something doesn't mean you should do something, because I'm sure we're all familiar with incidental findings and incidentalomas that are found on imaging. Is there any and maybe this would be a question for Marcus Bachhuber. Are there any studies that are showing that this additional AI process actually yields things that need to be dealt with, or is it just showing up things that, oh, we see this and maybe it has something to do with some future problem?
I think we will have to deal with this on a case-by-case basis. There may be benefits. I'm throwing something out there. Maybe there's a type of mammogram where if there's an AI protocol, they're better able to identify tumors. We might want to cover that, but we would need to see evidence that it is a value add.
Right. You're going exactly where I'm going, because just I'm sure we've all seen something happen where there's, oh, we're not sure what this is, do extra imaging or some additional test, and it causes the patient additional worry, or we may treat something that turns out to be a nothing. And that is essentially a patient harm.
Right. Yeah, I mean, and that's something that we need to balance. Yeah.
Yeah, but how
Thank you.
do you separate the AI part from just the diagnostic imaging part? Meaning, I could imagine.
So the stance that HERC has taken in the past is that, you know, a standard chest CT, we pay for that. And if you are gonna push a button and it runs through a piece of software and gives you additional information, we don't pay for that additional step. You can still do it. So that's what I was saying about additional manipulation of already acquired data.
Yeah, I just wonder, I mean, I'm a non-expert in this case, but to me, I wonder if these things will be so entwined that it's hard to separate the AI component from the imaging component.
And if they come out with like a single code.
Yeah, we deal with it at the billing code level.
So this is specifically, they're wanting to charge for
Yes.
the separate AI
For
thing.
pushing a button to say,
Right.
give me this additional information.
Okay.
So if they would have one code for a pathologist to read a scan, and a different code for the AI to read a scan, with different reimbursements around, we look at each of those different codes. And decide.
But like we
Before-
didn't wanna cover a particular type of mammogram for years, but then they took away the codes for that type and there was just one type of mammogram. So we had written a guideline saying we don't wanna cover this other type, but then we were like, well, who would know? So we just gave up.
Yeah, so we're
I
looking
would,
through the lens of the billing code. Sorry, go ahead, Larry.
I'd like to see some type of evidence that using AI in this manner actually improves patient care quality, safety outcomes.
Right, so for this particular AI intervention, that was not found, that's why it's on E2. If and when another code comes up, we'll try to do the same thing and see.
And I believe Val was saying this morning that our colleagues at the center are working on a report on several AI technologies. And so we'll be reviewing that and possibly bringing some topics from that.
Sounds great.
Well, yeah, I wonder, anyways, this is maybe a separate discussion. I wonder if the approach should be looking at AI, kind of governance and testing rather than individual AI capabilities, because the technology moves so fast.
Yeah.
Looking at a study published about a given AI technology is gonna be really hard, because the models will have changed, over time. But on the other hand, there are papers that we're kind of writing an AI paper now for ARC, but there are things being written about what you want to see in terms of scrutiny of AI in general, and whether or not these models have undergone that kind of scrutiny.
Yeah.
Otherwise, I don't know how you kind of get into the black box of it, without being a modeler.
From the regulatory kind of horizon on this, speaking malpractice and scope of care and standard of care, what we're seeing is that sometimes these AI imaging models are sold directly to the public, so the public could pay for, like, they could use their phone to look at their eye or something
Oh,
and get an AI diagnosis. And then the regulatory boards are worried about that because who is the licensed healthcare provider behind that, right? So as far as governance, it would need to be like, by a physician. And the other idea is within the kind of the governance is to have documentation. If you've ever used any AI for your management plan or in your diagnostics or anything, to say that you did. And
there's a dark side to this where someone who creates this AI program could have the program deliberately overread something so that additional procedures would be done, which would then rake in more dough.
Fair
Oh,
enough.
yeah.
So I
But that
think
goes
we
into
all
the-
agree that the AI,
yeah,
the particular code we're dealing with today, I didn't hear any disagreement
Yeah.
about. So I would vote to
yeah.
acknowledge AI as an upcoming issue and
Yeah,
move
yeah.
on.
Okay, fair enough. Great.
Sounds good.
Let's keep going.
Okay. So we went on to a couple of topics that had arisen out of our BEP discussions in January. The first is cholecystectomy for gallbladder polyps. The recommendation is to add coverage with a new guideline. So this is actually going to be effective October 1st.
What page? What page?
Daphne's looking.
Oh, thank you.
117.
Great, thank you.
So we would add the code, it's cholesterolosis, but it's used for gallbladder polyps, which are small growths in the gallbladder. And the purple wording was changed in January, so I have been trying to do version control. So if you see purple words, we're not making a decision about that, that's already done. So it's down in the blue words. So it would be covered for a gallbladder polyp that measures, these are based on expert guidelines, 10 millimeters or larger, or 6 to 9 millimeters if there's a risk factor from malignancy, which have been defined by various expert groups. Otherwise, we would not cover anything more than like additional imaging for monitoring. Any questions about that? The next thing we talked about was hypermobility syndrome, which is also
Page
called
122.
which is also called hypermobility spectrum disorder. This came up during our discussions about Ehlers-Danlos syndrome at the last meeting. Hypermobility syndrome or hypermobility spectrum disorder is a condition that's similar, related in many ways to EDS, where people have loose connective tissue, frequent joint dislocations, et cetera, but they don't meet EDS criteria. We had two options that were in the staff recommendation. The first was to make no change until 2027. The second option was to move the code. The code description is hypermobility syndrome, but it is used for hypermobility spectrum disorder. Kind of the same thing, most likely, but different. Used differently by patients and providers. The terms are move that to be with EDS. And then modify the new EDS guideline that we adopted in January to include some wording. There is a recent paper that had some criteria. They use a Baton hypermobility score, which is a scoring about various joints and how loose they are. and then have one or more other manifestation, like pain or, joint misalignment or something like that, and who doesn't meet Ehlers-Danlos syndrome. And then regardless of the decision for the current decision in 2027, this code will go on the evaluation and medical management line, which is where the Ehlers-Danlos code will go. It was a pretty robust discussion this morning. I think VBS members were mainly concerned about the fact that the diagnostic criteria were so vague. Even though they do use a score, they're very, that scoring is, many people who might consider themselves normal would fall into this range. It's difficult to it just seemed that it was difficult to kind of figure out exactly how you would determine that somebody really did have this condition. And the group this morning decided that they wanted to continue to keep this on a non-covered line until 2027. Of note, we did get 17 public comments on this, and all 17 of those commenters recommended the other option, moving coverage. They have expressed various concerns, many times things like they're having trouble accessing care, they're having trouble getting coordination of care or adequate pain management or other things. Very much echoing, I think, what we heard in our Ehlers-Danlos discussion, kind of the same systemic barriers. The group this morning did take into account all of the public testimony, but felt that nothing that we could do about moving this code would really address the issues that were brought up by the public.
Yeah, the coding wouldn't necessarily change issues around care coordination, access and so forth. And isn't it, if I'm recalling prior discussions, practically speaking, treatments are really kind of physical therapy and, outside of the cardiac complications associated with it.
Yeah, and this specifically wouldn't have cardiac complications.
Right, so you would be qualifying for physical therapy based on,
No, physical therapy is not proposed to pair with either EDS or mobility.
No, what I'm saying is that in either of those cases, the physical therapy is pairing with whatever target.
Right, the
part of the body
dislocated shoulder
yeah,
or
exactly.
the,
I have a question about this because it sounds like.
I'm sorry, Larry, Lisa had her hand up first and then we'll
Oh,
have-
sorry. Go ahead.
Okay, thanks. I'm just wondering on the claims side, because we're hearing from the public that they're having difficulty with access. So I wonder if in the claims processing, if they're using that hypermobility diagnosis code and the dislocated shoulder code, would using that hypermobility diagnosis code kick out the physical therapy? No, so it's not, okay.
Yeah, we heard different things.
Right.
Our expert that came November,
January.
said that she might not put hypermobility spectrum disorder or hypermobile EDS because it might lead to stigma or a denial, and we put the manifestation code instead. We've also heard from patients that services are being denied because they have those codes on there. I don't know if that's specific to OHP. We haven't done a detailed review of the chart notes. I think we ran a claims query and we found a mix of both. But you could have multiple diagnoses on a claim. The primary one pointed to is the one that gets evaluated. And so it can be a little bit difficult to sort out what's going on.
So in that example or in a scenario that you just said, if the hypermobility syndrome is diagnosis A or 1.
Right.
And then the dislocated shoulder is number 2. And
With
they
this
probably both would
proposal,
point to
it'll be denied.
It would be denied.
And again, when we
Because
reviewed, even
Feeling
for
that.
EDS,
Huh.
we reviewed getting physical therapy for EDS per se
Right,
and did not find evidence.
okay.
Yeah, so even if you use EDS now, even though it's on a covered line, if that was the primary diagnosis, it wouldn't pair with physical therapy.
So the provider needs to be educated to use the symptom.
The symptom being
Or
treated.
the current injury.
It
Larry,
sounds, yeah, it sounds to me like this is a rose by any other name. Because it sounds like if someone is having a problem because of this condition, whether or not the condition is covered, they still get care for the result or the problem due to the condition. Is that a fair statement?
Yes, and even if this diagnosis is on a non-covered line, they still get office visits, diagnostic testing, medications that do not require PA, and they would not get DME technically, although DME has its own rules for like,
Mhm.
you need a wheelchair for reasons. So if we moved it to a covered line, DME would flow a little bit, but they'd still have to meet all the DME criteria. And there would have to be medications that RPA would have to see if it's medically appropriate for that condition instead of just saying it's not funded.
And
So,
again,
so until this is revisited in 2027, should there be a recommendation to clinicians? Don't diagnose, don't use this as a primary diagnosis, use the actual symptom as the diagnosis. I mean, that would
I
sound,
think that was Lisa's point, that there might
Yeah.
be some provider education,
Yeah.
which is outside of the HERCS realm, but perhaps other parts of OHA might be able to do that.
I agree with that.
Do we influence coverage of DME at all?
in
Because I,
rare circumstances, we can.
because I could see someone who has recovered from their things and in order to play sports or do their job, they need to wear some kind of orthotic or brace. And I could see that they, even if they're asymptomatic, as a potential, if their knees hyperextend, you could wear a thing that limits the range of motion of the knee.
There's
So-
an OAR specifically against preventative use of DME.
Yeah, and
It's pretty
we'll
broad.
see later on at a different topic, we talk about orthotics, that's
Okay.
out of our wheelhouse, that's a
Okay.
goal, but we're going to be working with the folks who have the orthotic rules, for other reasons, but yeah.
Okay, so good discussion on this. Do we need to vote now on this or?
Why
just
don't
go
we do
through
the
it?
neuralgia paresthetica?
Okay,
That was neuralgia paresthetica is a rare condition where there's a nerve, that's
Page 142.
pinched, causing altered sensation on the side of the thigh. There are surgical treatments that for the folks that there's conservative therapy generally resolves this, but if it doesn't, there are some effective surgical therapies. So the recommendation had been to move this to a covered line to pair with the surgical therapies that are appropriate for it.
I mean, it's not that uncommon. We see it from time to time, often it's just loosen your belt kind of treatment.
Right, so the first line
Uh,
therapy is changing the clothing, and losing weight, which
Yeah,
was
I
a
don't
terrible thing to
know that
recommend
I've
to
ever
people.
heard of anybody being sent for surgery for this, but,
The literature does show that when people have have this condition that's so severe that it's really bothering them and it doesn't resolve.
Yeah.
That either injecting the nerve or cutting the nerve actually can resolve their symptoms very well.
Ariel, this is Mark. I'm cautious on this one because I see the recommendation is to remove it from the below the line peripheral nerve disorder and add it to above the line on deep open wound with or without tendon or nerve involvement.
Yeah, so the deep open wound line is a huge smorgasbord of things. It's basically injuries to things that are severe enough to need treatment.
Okay. And the other concern I have is this is almost a sensory type of issue. For example, you could have the same thing in your chest between rib type of neural type pain for a request for a neurectomy. I just don't see the thought that this is an above the line current consistent with other peripheral nerve sensory disorders. Is there more to it than this?
So this was identified when we were looking at the non-covered conditions that were below the line. This was identified as something that did have surgical interventions that work. Other conditions that would have neurectomy, I haven't identified below the line, so I suspect they're above the line. Whether or not they actually are paired with surgery, I don't know.
Tunnel, I mean, it's with that, they're not one of the things that definitely has treatment.
I can't tell you what conditions we have above the line that
Well,
would
that's a
have
different
neurectomy.
procedure though, it's a fasciotomy.
Yeah,
Fair enough.
Yeah,
Um,
just a little input on neuralgia paresthetica. Often it's not cutting the nerve that's done, it's neurolysis. So like releasing, there's sometimes some bands of tissue around the inguinal crease that are near the ASIS that can actually tether the nerve. So it's not usually cutting it, it's releasing it. I think it is a very, very rare condition that goes on to requiring surgical management. And it's usually in the atypical cases where the person is neither obese nor wearing a tight belt. So I think it's extremely rare and a low incidence situation in particular. And usually it's not like cutting the nerve, it's neurolysis that helps patients. Yeah,
well, I
they're
mean,
neurolysis. Yeah.
I mean, that's helpful, and that would have been my guess. I mean, so in that case, maybe we don't need to kind of ponder this too much if the practical impact is, likely to be on less than a handful of patients,
Yeah. And is it, just for my education, on the neurolysis, is it one and done, or is it something that has to be repeated every so often?
I've never seen recurrent neuralgia paresthetica after neurolysis, but again, it's something you don't see very often. Honestly, it's often in kids get this too. That's a strange thing. Growing children, for some reason, kids also who've had all sorts of surgeries around the hip, especially pelvic osteotomy. Sometimes the scar tissue that forms after those surgeries can tether the lateral femoral cutaneous nerve. So again, often this ends up being a pediatric condition, and I have seen it be pretty debilitating. But it's rare. The more common, more benign forms that are easily treated with, really just clothing modifications is the most common form, and again, also very, very easily treated with simple clothing modifications. So the most common form of neuralgia paresthetica is easily treated without surgery. Very rare to have surgery be something that would be even considered.
So, I mean, this seems to me pretty low risk for over treatment. I mean, hard to
if I
imagine
could loosen
that.
my belt,
Great.
Yeah, hard to imagine people are gonna be, lining up for an unnecessary neurectomy, but,
Yeah, it's a funny clinic visit when you just tell the people where the nerve is and that it's probably getting pinched by their belt. They and their
Yeah.
spouse usually giggle, and then problem is solved. Yeah.
it's very satisfying, but, all right. And so maybe we don't have to belabor this one.
No belaboring.
All right, what's next?
Next we talked about, I think we usually do the whole, oh, sorry, I'm so sorry. We next talked about colon manometric studies. This is a study looking at folks who have constipation that sort of doesn't respond to the usual kind of constipation things.
What page?
146.
46.
And our Marcus Hubbard, sorry, I can't even pronounce your name right anymore, it's been a long day. Marcus did the evidence review, which we looked at this morning. This is a pretty invasive test, and it is rarely, it's very rarely required. It's mostly would be required in children who've had like Hirschsprung's disease surgery to kind of see if there's any residual nerve problems or whatever. It is a very long invasive study. So the recommendation is to continue non-coverage with the understanding that in certain pediatric cases, EPSDT would allow for a review. Yeah, questions about that?
Yeah, it's that the procedure doesn't look like it's been reviewed in the past 15 years. Has there been any improvements in technology, procedure, or
Just reviewed now?
Yeah, I mean, I can speak to that. So we found 4 studies, 2 were systematic reviews, one from 2020, one from 2021, I think. Those were focused on children. And then there were 2 other studies from the past, since the last review of the service. And all the studies, especially the systematic reviews, noted that the technology was still in development and mostly used for research purposes, and protocols on how to do the study really varied between the studies that they looked at in those systematic reviews. So it sounds like it's very much an area of active development with an unclear place in clinical management right now.
Thank you. So my question is this: if this is going to be below the line, is there some mechanism where it would be appropriate for a patient in a rare case to have this? Can it be covered?
And
Yes.
Larry, we do see this mainly for EPSDT for children. It's not offered here in Oregon. They often have to go out of state because it's a very research heavy test, often done at Seattle Children's. I don't believe OHSU is
Yeah,
doing.
Seattle Children's is the closest.
Yeah.
So
Yeah.
if a kid needs this, is it covered at some point in some manner, even though it's
So-
below the line?
There is something called EPSDT, early and periodic screening and treatment, diagnostic and treatment. So any person under the age of 21 has to have an individualized review. So if, for example, a child had surgery because they had congenital problems with the colon and they've done all the other things and they've had a huge workup and they can't find the problem, a medical director could approve this.
Great. Thank you.
Okay.
Okay, any other questions on that? We had 3 biennial review items. They're actually
Page
pretty,
151.
Thank you.
they're actually pretty straightforward. We have 2 fingertip avulsion lines that are complete duplicates, one covered, one uncovered, so just deleting the lower line. We have 2 foreign body and the GI tract lines that were created about 15 years ago to kind of be specific that most foreign bodies in the GI tract just need observation, they'll pass through on their own, and then kind of pointing out where when you might get a procedure because they're concerning.
Page
However,
153.
The 2 lines are exactly the same except for one code. So the recommendation is to just delete the lower line, move that one code to the upper line, and then the current guideline can still stand. We just don't need to have the lower line there. It will just say, we only do endoscopy if you have certain high risk situations. And obviously if there's an unfortunate thing like a perforation, I mean, there's a whole set of other diagnoses that would allow the appropriate treatment. And then the last one was ill-defined malignant neoplasms. As you'll recall, we had one cancer line that was below the funding line that had very vague diagnoses.
Page 156.
Thank you. We moved all of the ones that I could identify an organ system to that line that was the cancers for that organ system. So the ones that are left are really vague. I was asked to reprioritize this because there are rare circumstances where this might be the primary diagnosis. And so what I did was I looked at the scoring, and it is currently at category 6, which is inconsequential care, like treating a cold. We're moving it to fatal conditions, and that would move this to about line 394. We do realize that most of these don't really have a treatment, and we talked this morning that some hypothetical cases like an older person who doesn't want a workup to come up with a final diagnosis might use this for palliative care or hospice. It's probably might be used before someone has a more definitive diagnosis. I mean, these are very, very vague, so I don't expect much utilization of these particular codes. Thanks for doing that work.
Are these codes, are they helpful for hospice care?
So my N of 1, I've had one example of a patient who was elderly, had a metastatic cancer with no obvious primary. She elected to have no further testing because she wasn't going to have any treatments, and so she had one of these as her hospice qualifying diagnosis because we didn't have a better one.
So, I mean, this is maybe more in the weeds than we need, but is metastatic cancer with unknown primary this one, malignant primary neoplasm unspecified, or is it,
I think it's the one above it, the disseminated malignant neoplasm.
oh, disseminated?
Or secondary I don't know, there's a couple.
What does
different ones.
secondary mean in this case?
That's the malignancy. So if you have lung cancer that spreads to the brain, you have a secondary malignancy of the brain.
It's the MET.
Yes.
Okay, that's just the term for metastasis.
Yeah, sorry.
Okay.
So I guess my question is having this diagnosis, does it help patients in terms of getting the care they need?
Possibly.
Best of your ability.
Yeah.
Yeah, I mean, because if you do for hospice, you still have to put something down.
Yeah.
If you don't know where it's coming from.
Right.
Then it sounds like it would be that, and unspecified. Okay.
Thank you.
All right. What's next?
Any other questions on that? All right, then we went into our benefit updates project. The first thing we did was the follow-ups from January. You all had identified multiple things that you wanted more information on. And really none of them changed the staff recommendation, except for those ones that I've already kind of pulled out, we've talked about further. But if any of you have any questions, we're happy to pull there's kind of a table of them. The one change we did make, for hypotension, you all wanted it paired with home self blood pressure monitoring. Yeah. We actually took those codes and made them ancillary, the blood pressure monitoring, because they might be used for various things, so.
What page?
198?
198. Okay. Okay, thank you.
Yeah, so hopefully that answered the questions that arose, and thank you all. I really appreciate when you do call something out, we can at least look at it and make sure we didn't miss something. Oh, and then we'll be getting to the congenital heart disease ones. So a few of these ended up spinning things off, and you'll see that. Spinal procedures, I was asked to look more at kyphoplasty, and in review of this, I realized that we
Page 205.
Thank you. We never voted on the entire BUP for spinal procedures. So we need to do that. And then the changes are, I bolded. What I ended up doing was pulling out kyphoplasty and vertebroplasty, making them their own code grouping that only has age-related osteoporosis with vertebral fracture. And then the procedure codes would be the vertebroplasty and the kyphoplasty. And then the current guideline, which is actually very restrictive, would be applied. So you have to be hospitalized with pain that hasn't responded to conservative therapy. And there's some other criteria, but it would be a pretty severe issue. Yeah, and then otherwise, I think you've seen all of these and you had no other real issues or questions with the rest of the spinal procedures when we looked at it in January. So there's the usual guideline note changes with sort of technical changes and then the code placements. Catching up a little bit. Sure, we can give you a second or two. We're doing all this detail.
Oh, here's a, just seeing something here, maybe you can clarify page 210 for spinal fusion procedures. It specifies MRI. So what if a patient can't get an MRI and you use alternate imaging?
That is our current guideline and has been our guideline for years.
Oh.
I suppose we would be able to work with the medical director that, a patient has a piece of metal in their eye and they can't have an MRI.
I guess I just mean, do we want to just add a note, a parenthetical note, if the patient can't get an MRI, the imaging evidence for spinal stenosis can come from a contrasted CT or whatever.
Max, are you seeing any problems with approving these if a patient is not a candidate for an MRI?
No,
Oh, they just have to, I didn't know how burdensome it is to.
I don't.
Okay.
No, that's a good point. I would assume it would happen more often. I can't recall.
Actually, MRIs are getting really good. There's a
Yeah,
lot
and a lot of the devices are
fewer,
getting-
That's
yeah,
true.
MRI safe too.
yeah, a lot fewer
Yeah.
things that you can't get an MRI for.
Yeah.
Sometimes they don't know.
But we still definitely have patients that can't get them.
So you have to, yeah, you've got people with weird metal pieces.
We, yeah,
that
we.
are-
I have
Yeah.
a question. Is what we're talking about here for the spinal procedures, is this consistent with commercial insurance coverage?
It's probably more restrictive,
Usually pains.
But I think better evidence-based.
yeah, yeah.
Anyways, I mean, maybe it's a minor thing, but it does come up.
And how common is that?
That people can't get MRIs?
Yeah.
I mean, I can't tell you off the top of my head, but, you know, enough that we all see people like that.
So
And
is that-
having reviewed, it's relatively uncommon for the MRI, but the neurosurgeons will generally provide the appropriate CT scan or other imaging. So
Exactly, yeah.
yeah,
We covered.
and we look at those. Those are looked at special.
Okay. All right,
Yeah.
so it sounds like practically it's not an issue.
No, practically it's not. They'll specifically say could not do an MRI and would do blank instead. So
Okay. All right, never mind.
yeah.
Oh, my apologies, I forgot, there's one other follow-up issue, and that was buried penis. It's a condition where you can't see the penis, usually because of the anatomy of the person. This was, the proposal for urology had included that you could treat an acquired anomaly of the penis if it resulted in buried penis. It was pointed out this is usually a result of obesity and doesn't need surgery. And I was asked to look at this again. Looking at it, the guideline had been modified based on our experts. Previously, there'd been a list of 8 or 9 conditions that had to have been the result of a prior procedure. And they wanted that changed because it could be an injury, it could be a medical condition that resulted in it. So we took that requirement away, but we meant it to but we really, I think what you all wanted was it to remain for the buried penis. So we added that to our penile anomalies guideline. So you can treat the anomaly of the penis that results in a buried penis only when it's the result of a prior penile procedure. Our pediatric urologist had said he sees this periodically, mostly from circumcision complications with contractures and things. So,
What page?
so
We're on page 203.
yeah, and it's on the screen. If you have.
Oh, yeah.
So I think this takes care of the concern that this group had. So the types that are resulting from obesity that we wouldn't want to do surgery on would be okay. All right, and then the last follow-up issue was cervicogenic headache, and I know we have some folks here who want to testify. So I just wanted to just kind of let you know kind of how this works. I will give you a summary of sort of the background and the staff recommendations. This group may have some clarifying discussion or bring some things up. Then we will allow the folks, I believe we have 2 people signed up for testimony. You're welcome to, since you're virtual, you'll be promoted to panelist, you can unmute, you can give your testimony. And then the group will again discuss. I would ask that you remain, please, if it's possible for you to remain, and if anyone has any questions for you, we'll discuss and then there'll be a vote.
So just a kind of procedural thing. Do we want to vote on everything else first and then do this?
We usually vote on the whole UBS.
Okay.
But, and actually most of the stuff after this
Unless you
is
think
tabled.
somebody's likely to disagree.
Well, I didn't know, I just,
Yeah.
to keep it clean.
Play with your
but,
goodness, go with.
Yeah, I mean, if people have really disagreed, we could maybe vote on the topic separately, but usually we vote on it.
Okay, that's fine.
And unfortunately,
page
most of the stuff
222.
after got tabled.
Okay.
So.
Okay, It's okay.
We'll go through the,
That's okay.
yeah.
And Ariel, we have one person here to testify. I
Perfect.
don't see the other person.
Okay, great. All right. So just to remind you all, cervicogenic headache is, it's currently on the non-funded pension headache line. This is a type of headache that's thought to result because of spinal or muscular problems in the neck that kind of radiate to the musculature around the head and cause the headache. One of the treatments for this is spinal manipulation, either chiropractic or osteopathic manipulation. That currently is paired, although this cervicogenic headache is not a covered condition. The recommendation in January had been to put it into sort of the headache code grouping and pair it with spinal manipulation. The concern that was raised in the January discussion was that there have been reports of adverse events with spinal manipulation, and staff was asked to get further information on that. So I did do an evidence review looking at the risks of spinal manipulation of the cervical spine. There was a systematic review and meta-analysis published last year. They found 14 RCTs. And these were compared to a variety of controls, including sham, manipulation in a different area, massage, et cetera, they found 187 adverse events in 31,691 person days. So very, very rare. And they basically that was the main point of that was just the rarity of it. There have been other, there was a VA evidence synthesis review from 2017 that found that mild musculoskeletal adverse events are common, such as muscle soreness, but that serious adverse events are very rare. And then there was another much older study from 2007 that found multiple case reports. Some of these were quite serious, but again, there was no denominator. So it was difficult to see what the rate of those severe adverse events were. And there was one study that was submitted that I reviewed above.
Was there any definition of mild, moderate, or severe adverse events?
Yes. I would have to look at each study individually. Okay. The severe ones included dural tears, nerve injury, disc herniation, hematoma, and bone fracture. Mild would usually be muscular soreness, bruising, tenderness.
Okay.
Yeah, so I'm wondering, I don't know, because the real severe injury that I think every neurosurgery and orthopedic surgery and probably ER physician has seen is vertebral artery laceration and yeah, hematoma in the best case scenario, and then often, devastating stroke.
So from the manipulation itself.
Yeah. My teeny tiny practice, I've had one patient with a stroke from.
I can speak to that.
Yeah, you actually do that. Yeah.
Yeah. So there's been, lots of case reports of that happening, and obviously it's a very horrific kind of, adverse event and everything, and so no one wants that to happen. There have been lots of studies done to see if there's actual causation. So there's correlation, and studies that have been designed, to look at causation or weed out the correlation found that because the early symptoms or the symptoms of cervical artery dissection kind of in progress can be neck pain and headache, and it may not be discernible from regular neck pain and headache, and there may be no neurological symptoms going on. They found that the incidence of patients going on to have a stroke after the chiropractic adjustment versus if they went to like their primary care doc were the same. So and lots of other studies have looked into this, and a good one that I like is in 2016, I can also send that, or I think that was a systematic review, and it was done by a group of neurologists out of Penn State, and they looked at they included some of these other systematic reviews and reviews that included large data sets. So they have access to that in Canada a lot because of their care system. And they also concluded that there is no evidence to support causation. So it's this causation of the cervical artery dissection that is not found in the evidence when you look at before and after kind of thing. And then there have also been lots of studies done on either cadaver animal models, or as close as you can get with like fMRI, where you're watching blood flow and you're watching tension on the arteries, even the carotid artery, but the vertebral artery, and the proposed mechanism that the adjustment, the movement of the neck and the stretch on the artery as being, the mechanism for that artery dissection it's not panned out. So the change in the hemodynamics, the stress on the arteries have not been found to go beyond what would happen in daily activity. So someone turning their head all the way over is more than what happens in the adjustment. So there is an association because people can go seek care from their chiropractor when they have headache and neck pain. And if there aren't any neurological symptoms, it can be hard to know what's really happening. It's it is politicized, and it may be a little disconnect just between the different professions. Yeah.
Headaches are just a headache.
Quickly on that reference to the stroke and chiropractor, and mainly because I work in the ER and have seen this, is there a date on that study? I just would like to look at it because there's quite a few studies that do show a correlation, and I know there's conflict and there's discussion about it, and so I do know there's studies on both sides, but I would definitely like to look at that one because I'm not sure if it's confirmed.
And the study that I found that showed vertebral artery dissection as an adverse event was from 2007, and again that was just looking at case reports, so it didn't have a denominator. We don't know how.
Can't get this to anyone in the chat, but it's by Church, published in Curious or Serious 2016, called Systematic Review and Meta-Analysis of Chiropractic Care and Cervical Artery Dissections, no evidence for causation. So yeah, there is this association, and but the association is likely explained by a patient having some symptoms that go along with the cervical artery dissection, and even some of these dissections are asymptomatic. So, and the artery dissections can happen more with, I think they're almost more related to hemodynamics within the arteries if there's malformation. So often people have connective tissue disease disorders with this and don't know that they have it. And also people can be more prone to this if they say are pregnant or recently were pregnant because of the increased volume of the blood. So it already kind of makes that artery susceptible to the changes in hemodynamics. So, and it hits the crowd around the 45 age mark is more kind of the common parameters.
I wonder
just to kind of piggyback, you had a systematic review and meta-analysis of Pancrath et al. In 2024 that was in your packet.
Yeah, that's
they controlled with, in many cases, just other things like massage or supervised exercise or nothing or ibuprofen or whatever. These were all RCTs, so they note that they were not looking at adverse events as a primary outcome, but they did report them. And the conclusions were that, they couldn't draw a causal association between the adverse events and the cervical manipulations based on this particular.
Or even,
Systematic
or even association, because the frequency was similar, so there wasn't a statistical difference between the adjustment and the control.
But that's gonna, I mean, it's a challenge from trials.
Yeah.
Because, I mean,
Yeah,
I think everybody will agree that if this does occur as a complication, it's rare.
Mhm.
But because it's a devastating complication, even a rare event is worth paying attention to. So a trial is not gonna be able to tell us, and then you're stuck with observational data, which by definition can't really prove causation regardless. So you know, I think we're gonna be a little stuck here without really knowing. You know, I would wonder about things in the case series if there's timing things. I mean, I think that point is a fair one, Lisa, that the same people that are getting these procedures done are having symptoms that, you know, are associated with this complication anyways. But, you know, if there was a case series where all the vertebral dissections happen like within, you know, 24 hours of getting the procedure done, you know, that kind of, the timing of it, you know, would help. And I don't know what the case series showed, but, you know, if these case series are kind of showing that these are happening at just random times and there's not really a time association with the manipulation, then it'd be harder to believe the relationship between the two. I guess the bigger point is, say it is believable that manipulation rarely, you know, 1 in a million or whatever can cause this kind of complication. How would that impact decision-making on coverage? Do we not cover something because of a complication that might be 1 in a million? I'm making that up, by the way. I have no idea what the number
Serious
would be.
adverse events were found to be 6 per 10 million.
Yeah, so, yeah.
And that's
That's
You know,
less than one.
yeah, it's less than 1 in a million and it's a broader group.
Yeah, so I wonder if we want to structure the discussion in that way. Pretend that it is a real complication, but that its incidence is
Less than 1 in a million.
is rare. You know, would that affect coverage? I mean, there's many things that we do cover that have
Most surgeries have a death rate.
fatal,
even.
you know, complications of,
Yeah.
you know, at that rate or higher.
I think there's a little bit of an elephant in the room, and that is the clinical assessment done by the practitioner.
But how would that, I mean, because do you mean like patient selection would help mitigate the risk, or?
Yeah, I mean, the practice of medicine is imperfect by nature, and clinical evaluation and appropriate patient selection is the key here. We have the potential for a serious adverse outcome at a very, very low rate. I'm not sure that there is a way to control for that other than proper assessment of the patient, and that's up to the clinician.
But that's
Yeah,
another,
so-
sorry, go ahead.
So I just want, I know we have someone here to testify, so I just wanted to kind of, my summary
Yeah.
was that manipulation does have evidence for harm in a very, very, very low rate. But it does seem to be effective in the short and medium term for pain, although the evidence for long term is not good. Other insurers do appear to be covering this. So the staff recommendation is basically what you saw in January, to add chiropractic and osteopathic manipulation to the migraine and tension headache line. And then the current cervicogenic guideline would basically just be attached to that with just technical modifications. So it would only allow the manipulation for cervicogenic headaches, not for migraine and tension headaches and other things on that line.
I do have a question about that because if we're looking at chiropractic manipulation, we're also including in this osteopathic manipulation. Does osteopathic manipulation have any similar type of adverse event rate?
I think they're generally lumped together. Max, do you have any?
I can speak to what they taught me in school, so I don't know how
Okay.
evidence-based, and I can't cite the studies, but the technique that we use is slightly different from what I was taught, because we do high velocity, low amplitude, so it's getting closer to moves less, and what they taught us in school is the complication rate was negligible and much less than larger amplitude interventions.
So if I understand you correctly, that osteopathic manipulation, would it make follow through and make sense then that there's a lower adverse event rate than with chiropractic manipulation?
I think Lisa had a comment.
Yeah, so I don't think the characterization that osteopathic manipulation has less movement than chiropractic manipulation would be accurate, because we also call ours HVLA.
Oh.
High velocity, low amplitude. And physical therapists in different countries, and some physical therapists are starting to do this now, is use HVLA adjustments as well. So the HVLA manipulation has been used, and a lot of times the osteopathic manipulation has been lumped into some of the studies.
Okay.
So,
And the HERC has always treated them as the same,
Okay.
yeah. I think
whether or
there's-
not that's true.
I think there's a lot of different techniques, and so I think that would be reasonable.
I would suggest that we let our our person who wants to give testimony give us their testimony, and then we can finish our discussion.
Sounds good.
Thank you very much. Today we have speaking Craig Kawaoka. This topic may be sensitive for some, and as a reminder, HERC is a policy-making body and can't make decisions about coverage or care for individuals. Any policy changes resulting from today's discussion will go into effect at a future date. These discussions may be intensely personal for some, and yet in this forum, we tend to discuss topics that may seem clinical and impersonal. Not everyone's experience fit into the picture that the clinical evidence shows. Please be aware that our commission's business is to make the best possible decisions for the general population using HERC's methodology and processes to determine the importance of services. Today, we're having one person testify, and we're setting a timer for 3 minutes. A progress bar will show how much time is remaining. And after your allotted time ends, if you would stay in the meeting in case members have questions for you. Before you begin your testimony, we'll ask for your name and any conflicts you have regarding this topic. One moment while I set you up to participate. All right, Craig, the floor is yours.
Hi, I'm Craig Kawaoka, licensed chiropractor that works for the Oregon Board of Chiropractic Examiners. I'm not here to give any testimonies because I think Dr. Kouzes did a good job with that. I'm here mainly just to answer any questions that you guys may have about cases or anything that we do have. I've been in the academia world for over 20 years. I have been, I've been directors of sports medicine programs, and I was a clinical educator at 2 universities and stuff, as well as numerous community health areas and stuff. So if you guys have questions for me, that's what I'm mainly here for.
Great, thank you for coming. Well, I guess with that, do people have questions for Craig?
I have a question.
Dr. Lyon, I'm having trouble hearing you.
Oh, can you hear me now?
Yes, I
Yeah.
can. Thank you.
Okay, all right. So has the chiropractic board come across any of these serious adverse effects that we've been discussing?
Yes, in my time, I've only been with the board for a little over 3 years now. In my time, we've had 2 cases. Two more have just come up recently that I need to do some investigations into the cases. Ironically, the 2 cases, or maybe there was three cases, it was brought to their attention that this was potentially a chiropractic manipulation that caused the event by the ER personnel. So then they came up and filed a complaint based on that. There's also a Facebook posting apparently out there with people who have suffered strokes post cervical adjustments. And so there's a group of them that are also out there bringing it up.
Has the board tried to do any type of analysis of these kinds of events to see if there's any either association or causality?
We don't operate that way. We're administrative law. So we don't operate in that capacity. We have panels and we have groups that may look into that, but us as a board do not do that.
Have any of those panels done any investigation?
Not as that I know of.
Okay.
But I'm fairly new to the board too. I haven't been around forever.
Yeah.
Do you have a professional or clinical opinion about the risk of chiropractic cervical adjustments and causation of cervical artery dissections?
I mean, yes, it's one of those things. It's more of a, for me, in my experience and stuff, it's more of a coincidence, or there's other factors that are involved with what's going on. I mean, you brought up a couple of them, like any congenital defects, any previous history, family history of strokes. God, I can't think of all the stuff. But there's a lot that's out there, and it's unfortunate. Some people may be on the verge of having a stroke, and then through the chiropractic manipulation, it may just send them over. They may have had the stroke another time. Not saying that, I mean, and there's also different ways of adjusting necks. Some people are aggressive, some people are not so. We've also seen studies that, massage therapists who do massages around the neck and stuff may also cause those things. So it all gets lumped together as opposed to separating out who did what and why this was caused. It just says it was a manipulation and that was it. So, but they really haven't found, at least the studies I've read, there isn't no causality, or they said, yeah, this was the mechanism of why these people had stroke. There's always an underlying things. In fact, one of the cases I looked at, that they did look at a tortured artery within the cervical thing that was already there, and it may have led to the stroke.
Well, yeah, I mean, again, I think it's going to be really hard to prove or disprove causation with the type of evidence we're talking about. I mean, to play devil's advocate, even if people are found to have other risk factors which might explain stroke, it doesn't mean that manipulation can't have played a causal role, right? People that are at higher risk for stroke would be at higher risk for a complication that would lead to stroke. So that's also true. I mean, the risk factors don't explain away it. It also doesn't prove causation. Again, I mean, I would kind of look for case series. Yeah, we got 30 cases and all of them showed up with stroke within 24 hours of having this procedure done. I mean, that kind of would be helpful. Catherine, go ahead.
Yeah, I appreciate the causal versus correlation question. I do, that's not, I don't think what we're here to do. I do think, though, that, if a person is having symptoms that prompt them to seek chiropractic manipulation when those symptoms overlap with symptoms of concerning things like vertebral artery dissection, impending stroke, things like that, then I don't know that we want to like direct them towards the manipulation if that's something that could precipitate a worsening of their situation, which, in the many, short series or descriptions of cases of this situation all kind of describe that pattern. So I agree. Is this a cause or a correlation? I don't know, but I still think that there's a concern here, and that the harm needs to be considered. And right, it might be the evidence might point to be so, infrequent, but it can be devastating. So I think it just needs to be considered, and I appreciate the literature review. I've, done a similar one, and there's a lot of literature. It doesn't often meet the standards that we're using here. But there's certainly when things are uncommon, it's really hard to study them in robust ways. I think we all understand that. But that doesn't mean that they're not, significant catastrophic events.
Yeah, no, I agree. And I think what I meant by the caution about the study design is that we often will relax, study inclusion criteria for harms, because you want to design things to be, kind of overly sensitive to detect harms, because we're a profession, whose philosophy is to do no harm. So, we do want to pay attention to observational data about harms, even though it can't prove causation, because we want to err on the side of thinking about the harms, at least thinking about them. So for our purposes, as an exercise for this discussion, I would say, let's, for argument's sake, say that the literature does show that there's a rare incidence of serious harms associated with these, but there's also benefit in, a much larger number of people. I wonder if that would be a useful way of couching our discussion about this. Would we approve this if a lot of people got a lot of benefit and the serious complication rate was 1 in a million?
We also cover cervical manipulation for other conditions referred to as less.
Oh, okay, that's a good
Yeah.
point. So,
Yeah.
except the difference here is that
What was that point? What was that point?
We cover cervical manipulation for cervical spine pain. I'd have to look, but we cover it for other conditions.
Chris, go ahead.
Chris Pinzon, did you have?
Sorry, I'm just I'm hearing that some of those rare events are actually defined. Is there any kind of workup to evaluate the risk before approving or directing them towards those procedures? No, Caitlin's shaking her head. Bummer.
Speak to that.
Well, yeah, so I mean, there are proposed pathways that might eliminate. However, there is no orthopedic test that you can do that is worth anything. And even the algorithms that I've seen, and I've worked on malpractice
invasive
cases.
vascular study and see if
I know you'd have to do vascular imaging, and headache and neck pain, and that's every day. So there are ideas of having an algorithm to follow, but often patients don't present with anything more than neck pain or headache. If they have those neurological components, chiropractors are trained to see those. I have a question for Dr. Kawaoka. Since you've been in academia and regulation, I'm assuming you would agree with me that treating headache, neck pain, back pain, those are basically the bread and butter of the chiropractic practice. What would your response to that be?
Yes, it is. That's what we do. But like you
Yeah.
mentioned, yeah.
And then another question is, so we have lots of clinical training. We have full, I mean, we had full cadaver training, all the organ systems, 4 years of education. Generally, we have national boards, 4 parts, and those national boards also include watching people adjust fake patients and analyzing all of that. And do you feel that the chiropractic profession has been regulated for public protection and patient safety?
Yes.
I think someone pointed out earlier, we cover many things that have a 1 in a million. I mean,
Yeah.
an appendectomy for appendicitis probably has a 1 in a million death rate from the
Right.
anesthesia.
Yeah.
Yeah, so a lot of this stuff has higher complication, which is kind of the point of the exercise I was bringing up. Let's assume there is a serious adverse event rate, but it's rare. Would we cover it? And we'd have to have this discussion because we cover a lot of things that fall into that category. And so I think as Lisa's kind of alluding to, we have to be cautious about, there's probably some, I'm as guilty of this as anybody else, but we all kind of know the profession we know, and so it can make it harder to understand a profession that you're not part of. So I do think we want to be cautious about how we're interpreting risk and benefit.
And I would second that on the risk and benefit, because I've had patients that just letting them know the risk of blood HIV transfusion is 1 in 5 million not receive blood. So I guess my concern would be is, do providers tell their patients that the risk of stroke is 1 in blank amount? And my experience has been that most providers do not tell their patients. And if they did, even with these very low odds, many patients would not want the procedure done.
I can speak from my personal experience. So when I went through school, we were trained to disclose that, and that's what I did. And I didn't have anyone say no. So
because they're in pain.
Yeah, they're in pain, and I mean, I said I can injure the bones, the ligaments, the nerves, the arteries. Chance of stroke, I think at that point was like calculated as 1 in 3 million. I mean, I said these, you can look at different numbers at times, but nowadays, what I've said is that same thing. And then I've also said, and the literature is supporting that it's not causal, that there could be this kind of thing already going on. And so it alerts both of us to think, oh, do you have any artery issues? Have you had blood pressure issues lately? And then also it can just alert the patient that if they have weird stuff going on, to go to the ER. But it has not, it's not been, no one with a headache, leaves it's not been a big, I'm done.
Yeah, I mean, it's interesting to think about this in the context of, like the COVID vaccine. Tell people their risk of serious complications is 1 in a million,
Yeah, I think, yeah. There's, with HIV, I think there can be, that's a heavy word, so.
Right. I'm just, I think in surgery and regarding an appendectomy and the risks for, general anesthetic for any sort of surgical condition, I think, that comes with, 2 separate consent processes. One that's very regulated and formalized, that's done by a surgeon, a second time by an anesthesiologist. So 2, very formal consent processes where it's a whole discussion. Patients have to have a chance to ask questions and answer them. And there's a risk benefit requirement for us, to do those things. So I don't know if those standards exist and if those discussions take place, if they're required, if there's documentation that's done, if there's a legal standard.
I can answer that. So we do the regular PAR-Q, which sounds kind of like what you have, and it does need to be documented. And so there are opportunities for answers. Even if if a clinic has a form, they're still required to go over it with the patient and get those questions addressed and things.
And then, so it's interesting also to hear, I mean, the other way we also deal with this on the medicine side is if there are complications, there's a review process, there's a board, there's a way to identify, people that are having a lot of complications, that kind of thing. It sounds like the same is true for.
Well, we have we're not as centralized necessarily. I would say chiropractors are more in smaller clinics or in small group practices with other types of providers, but there are several, I was just looking at this recently, there are several reporting mechanisms, but it's not quite as robust, no.
You have to be licensed by the state.
We're still
subject to board
absolutely
review.
Yeah, licensed and yeah.
I mean, these are good questions. Yeah, go ahead.
The VA uses chiropractors, and I am just yes, and I
refer a lot of patients.
I am just wondering if there is any data from the VA. Here is something from the VA: effectiveness and harms of spinal manipulative therapy for treatment of acute neck and lower back pain, systematic review from 2017. Marcus, did you or your group take a look at that?
That was in your packet. That's the
that is
article.
that is okay.
Yeah, and they didn't report any serious adverse events in the studies that they looked at.
They did not.
For cervical, for back, they saw basically transient mild musculoskeletal events, but then they recommended that if you were really serious about looking at adverse events, you should look at case reports. But assessing causality has proved challenging.
Yeah.
So rare. Yeah.
Right. Yeah. So again, that's where you come back to. Like I said, I would do this assuming that there's a rare risk, and then actually proceed. And you're right, Larry. I mean, we've been able to refer to. I mean, we actually have a chiropractor on staff now, and we've been able to refer, for the last 5-8 years, something like that, and we refer a lot of people because there's nothing else we could do for them in clinic, really, for a lot of these conditions. So that's been just my clinical experience. Okay, so I don't want to get too stuck on this. We're going to keep going around and around with this same, and at the same point, which is that we've got a procedure that seems to have evidence suggesting that it may help with this symptom that's painful and that a lot of people suffer from, but may have a rare complication associated with it, which, if it occurs, is devastating. So with that, how are people feeling about it? I said, Liz.
Well, I'll say, I am comfortable with this procedure being covered, but with a couple of caveats. And one is I really like the idea of informed consent, and by the same token, I really like the idea of, making sure that clinicians really are appropriate in terms of patient selection. But I don't know how we can say that from our standpoint.
Yeah, Larry, that's a challenging one because we've run into this before with these issues that have nothing to do with chiropractic care. Any profession that have to do with kind of professional oversight, and how does that work, and how do you mitigate against people not doing things the way they should? So unfortunately, I don't think we can play a role in that. Sorry, go ahead.
Do you feel comfortable at this point just calling the vote?
Yeah, maybe. Yeah. So maybe that's the next step. We can call it. I just try and get a sense of the room.
Like a straw poll?
Yeah.
No,
we can just What,
I-
we have to vote on everything, or just?
I'm sorry, what was the suggestion?
We're talking about just voting on this, the cervicogenic headache, topic right now. So I was just trying to get kind of a straw poll or to see if there's any other thing. So one of the things Larry's bringing up that, hang on one sec, sorry, is it possible in the language, if we do approve it, to say something about, with an informed consent process or?
No, so we're basically our levers, our payment.
Mhm.
So we would have to then have everyone submit a signed and informed. We don't do that for any other procedure. It's considered to be sort of standard of care. We would assume that the chiropractor or osteopath would have done that.
Okay, so we can't really do much with that, but any other thoughts or concerns before we vote on this one?
Can we ask for instance, the chiropractic board or OHA as a whole to pursue the other ideas that we're talking about, since we're only going to deal with payment?
Craig has his hand up.
If I understood correctly, the informed consent is part of what chiropractors have to do as part of their standards of practice. Is that what I heard you said?
Yeah, we have the Parkey process.
So they'd be vulnerable to board discipline if they did
Yeah,
not.
board and malpractice.
So that's already in place.
Yeah, and also I would assume patient selection, just like any other medical provider, if you felt the patient wasn't appropriate.
And on that topic of patient selection, there was public comment from the University of Western States, which is in Oregon, and it has the chiropractic program. And so it was their, I forget the title, dean of the chiropractic college, maybe. So Marty, she submitted.
There's written testimony, right?
Yeah, so the public testimony that came from the local school here. And it goes over that students are educated in treating headache, and that they do have training in, all components of physical exam, neuro exam, orthopedics. I mean, it's the same testing as the allopathic,
I just
procedures and things and training, really.
Yeah.
Just
I think that good training always important, and to revisit that periodically. My only concern is if your only tool is a hammer, you see every problem as a nail.
That's true. I would argue that's true of every single subspecialty we
Right. Yeah.
deal with in this on this committee. But that's going to be an evergreen.
Yeah. I just like to speak of, I don't have any training in cervical manipulation, and I can't imagine that, chiropractors have the exact same training, as neurosurgeons and orthopedic surgeons and allopathic physicians and things like that. So I don't think the training is equivalent. I think, there can be a statement and a belief that the licensing procedures and the standards of care, are upheld to a reasonable degree, and that within the standards of care, informed consent is done in the chiropractic community. That can be something, that is stated and upheld, and that's okay. But I don't think we can, assert in this, forum that the training is equivalent or identical.
Yeah, very, very fair point. Very fair point. I think what I can reiterate is the components of an exam. So observation, range of motion, or deep tendon reflexes, muscle testing, the sensation, the orthopedic tests. Those are shared between the professions and the diagnostic, diagnoses and things. That part, it's
Okay, I'm afraid we're gonna keep going around and around in this. We're getting there's a lot here, but we can't kind of oversee a profession or kind of get into that. So
I did have one more question.
Yeah.
I heard this is short-term gain, not long-term. How many episodes does it take? Is this a chronic treatment that is twice a week for a long time, or is this a one and done? I guess I just need to know a little bit more. We didn't go into the efficacy very much.
We did in January. Let me pull up my January notes. No, probably not. Let's go to January.
Also, I'll just say, the public comment from the university does have some samples. I believe in there has some samples, or at least it has studies with
Yeah, it says
duration and treatment strategies.
Yeah, 4 dose levels, 0, 6, 12, or 18 sessions, treated 3 times a week for 6 weeks.
Yeah, so, and in general, it's going to be the chiropractic standard, that you have a treatment plan, you want improvement within 6 weeks, you do a trial of treatment. If you're not having significant improvement in 6 weeks, then you need to reevaluate the diagnosis or the management. So those kind of standards are still there. I know we hear about outliers, and that can be, I think, in any profession, and that can be a little more for the board to handle. But it's definitely the model of treating a condition that you need to have improvement to show any further.
Yeah, and in January, we reviewed a couple of systematic reviews. Their studies were 3 to 20 sessions over 1 to 12 weeks in one of them. The other systematic review was 3 weeks of treatment with unknown numbers, and 6 to 16 sessions over an unspecified period of time.
And and I can give like my personal experience. It may be dependent on the patient, but a lot of times with headache, it can be 1 or 2, and they're 1 or 2 visits and they're totally fine, or they come back, they get a headache that, just kind of keeps coming back from work stress. And so I would see them for that and they'd be good after 1 or 2, but then it comes back because they still have work stress. And you can teach posture and stretching and go for a walk and that kind of thing, but it can be episodic because headaches can be episodic.
Sure.
One last question. Ariel, for the benefit update, will we still be limiting chiropractic visits to 30 visits per year with massage and acupuncture, or is that is that for discussion as well?
That is only for back pain, and it would not apply to this because this is actually going on the headache line.
Okay, so this would be in addition. Yeah.
I have one final thought on this subject, to pay attention to what Devin is saying, so we can get through this. I am in favor of payment for this, but my question is this: it would be really interesting to see if there is any specific relationship between the number of neck manipulations, and see if there's a relationship between that and these significant adverse effects. So if numbers, but that's for someone else to look at.
Okay.
Craig is on the line.
At this point, we have more to get through, so just to kind of pull us forward, we have a couple options. We can approve coverage of spinal manipulation for cervical headaches as proposed. We could table it and ask staff to put in a treatment limit. We could look at all of our coverage of cervical manipulation, which includes the back lines.
Can we try? Can we try just voting on what's before us?
Yeah, I agree with Devin.
Approval of this, basically. So why don't we go ahead and anybody want to move, create a motion?
I move. This is Larry. I move that we move ahead with voting on the proposal as it is.
Okay, thanks.
So you're, just to clarify, Larry, you are proposing, approving the staff recommendation as presented.
He wants
That's
to move it, yeah.
That
Okay.
is correct. That's right.
I said it wrong, yeah, so, yeah.
I'll second.
You're second, okay, so we can vote, we do the roll thing again,
roll.
Jessica.
And this vote is only for the cervicogenic headaches. We'll vote on the entire BBBS package later.
Yes.
All
All
right,
right, so we have to call the roll. We have to have each person say aye or yes, or however you want to respond, or no, or
So Jessica, we may have lost Jessica.
Jessica
I'm here.
or Daphne.
I was waiting
go
for a
ahead.
second. I didn't hear a second.
Oh,
Yeah,
Lisa,
yeah, we got one.
Second,
Lisa
sorry.
Cruz is seconded.
Okay, sorry about that. All right. Adrian Irwin's absent. Mark Buckholz.
No.
Mike Collins.
Yes.
Stacy Geisler.
No.
Max Kaiser.
approve.
Lisa Kouzes.
Aye.
Linnea Lindsay.
Yes.
Lawrence Lyon.
Boy, I'm still thinking about this. I'm abstained for right now.
Chris Pinzon.
Yes.
Katie Shable.
No.
All right, we're cutting it real close here because we got 3 no's and we have a couple people absent and we have an abstention. So
Devin needs to vote.
Yes,
okay.
Well, okay.
So Devin Consagra voted yes for the record.
I think Larry still has to vote.
No, he abstained.
Yeah, we,
You said for now.
we encourage people to vote if at all possible.
Yeah.
We need to have decisions.
Can I ask Mark a quick question?
Sure.
Mark, what is your reasoning for no?
The reasoning is there's no limits on treatment length, duration, and I'm concerned with the adverse outcomes.
Okay, thank you.
Would you all feel more comfortable bringing it back with the treatment limit outline?
I would.
Okay.
So
We had 4 ayes.
No, we had 1, 2, 3, 4, 5, 6 yeses. We had Collins, Kaiser, Kouzes, Lindsay, Pinzon, and Consagra voted yes. We had 3 no's, Geisler, Schabel, Buckholz. We had
Okay.
1 abstention. Why?
So
Okay.
then
All right, so
the motion carried regardless.
all right, but I'm gonna register my vote. My vote is gonna be no because I agree with Mark. I think we should have this come back and determine some limits on this.
Can we still look at that anyways?
Yes.
Okay.
We can approve this and you can direct staff
Do you need
to
another motion?
talk to our chiropractic colleagues and come up with a reasonable.
Okay, so we'll approve it and still come back with treatment limit discussion after her staff has had a chance to investigate.
Great. I'm comfortable with that.
Okay.
This is Chris. Katie, can I ask you why you said no?
Yeah, I mean, I'm in the biased position of having, seen several patients with devastating complications. That hard to know, is it caused by cervical manipulation? If it was a patient who didn't have a stroke, had a cervical manipulation and had a stroke, those are just devastating situations to be a part of, and they make an impact on you. And I think there are lots of treatments, for headaches. And I think those patients, had they known that was going to happen, they certainly wouldn't have done it. And, bad things happen in my line of work all the time. And I spend a ton of time talking to people about it and treating adverse events. And those were, really horrible and catastrophic things that impacted me. And I have concerns about the safety. I also don't like the fact that there isn't a limit on the number of treatments.
So I have a question for Catherine. So with Mark's idea of limiting the number of treatments, does that make you feel more comfortable, or are you still wary?
I'm still wary, but I would certainly listen to the presentation with a thoughtful and open mind.
Okay, thank you.
Okay, Stacy, and then we're gonna move on.
Yeah, no one's asking why I voted no, but just, it's okay. I'm the oral health lady, but just speaking as an epidemiologist, I'm just concerned about the quality of the evidence.
Yeah.
I think we really should apply the same standards to all disciplines. I appreciate rare outcomes are difficult to study, but I think really we should exercise equity in the science. And if we're going to have certain beliefs about poor evidence and other disciplines, we really should apply it fairly to all. And I also agree with Dr. Schabel about these outcomes. They can be extremely devastating, and I think that does deserve more of a look at that.
Yeah, Stacy, just to be clear, I totally agree with you, but I came to the opposite conclusion about the quality evidence there. That in a sense, my argument was, regardless of the causation correlation discussion, you can't really prove it through observational data. So one should err on the assumption that there is some causation there, and that there is a rate of serious adverse effects there. And so that's what I was trying to get people to do, assuming that there was a real rate. So, I mean, just for the record, I don't believe, because I totally agree with you. And if I thought we were not applying the evidence equally, we shouldn't, we should re-vote, but I don't think that's the case, in my opinion.
But if we assume that there is an adverse event rate for this procedure, then we should actually exercise more caution.
I mean, I was asking everybody to vote with the assumption that there is an adverse event rate, but that it's rare. And so, but that this is true of every single thing we cover. I mean, not every single thing, but yeah.
Ibuprofen has a pretty bad adverse event rate.
What's that?
Ibuprofen has a pretty
Oh,
bad.
I mean, yeah. I mean,
numbers.
there's a lot of stuff we do without thinking about it.
Those numbers, it's
But you know, so there's obviously we're all familiar with just that's part of medical, dental, any practice. This is going to be true. So, anyways, I just want to I agree with you, Stacy, but just for the record, because I don't want us to come back to this thinking that we had applied different evidentiary standards. I don't believe that we have, and at least in your votes we shouldn't have. But please correct me if I'm
right.
wrong.
And well, yeah, I think there is a little bit of a misinterpretation there, or I don't think of it the same way. When we talk about risks and benefits of invasive procedures or dangerous procedures in the surgical world, we're weighing risks and benefits, and
right.
And it is hard to do that when the data isn't good, when there are rare events. That's really, really hard to do with patients. But you brought up appendectomy a few times. I mean, people can die of appendicitis and sepsis, so you're doing a dangerous thing that does have a risk to, prevent and thwart other terrible outcomes, right? So, in my mind, a catastrophic, a vertebral artery dissection and stroke is a really bad outcome for the treatment of a headache, and so for me, those have a mismatch. And I think, I've got some information here today about the informed consent process that chiropractors use. I think that was very helpful for me. I think that moves me toward being reasonable. I think, unfortunately for me, the experiences that I've had around this were very impactful. And I'm not sure that I would change my own personal vote, but I understand that the group moves this, has approved this. So, I can certainly understand that, but I still need my vote, to be no on this one.
No, that's fine. And nobody's asking to change it. I'm simply, and I'm not trying to argue anybody out of their vote. I'm just trying to make sure we apply the evidence fairly. I believe we still are, but, and I will say for the management of chronic pain, which I do a lot of it, and the internist would, but there are real harms to, so it's not as though the management of headache is easy. It's actually quite quite challenging, and a lot of the downstream interventions people end up on, including in the past opioids, carry with them serious risks that we certainly kind of undertook wholesale as a profession for many years, but so I do think that there, even though there's not the immediate kind of sepsis concern, things like that, there are serious impacts of the alternative treatments.
Okay, so again,
anyways,
the
we're
vote
gonna move
is
over.
6 to 3.
Yes.
This is Chris. I think I'd like to change my vote because I guess what's resonating with me, what I'm hearing is it's a specific treatment for headaches where there are a lot of other things that we could do that don't have this severe debilitating consequence. And I don't know that
we are going to bring this topic back to the next meeting.
Okay, great.
We did have a vote. We'll record that there was some further discussion, but you're going to have another chance at this with some time to reflect and some additional options to consider. I'm just moving us along because we do need to get to the other project.
One final comment. I really appreciate the discussion, and I really appreciate Stacy, Catherine's, and Mark's input. Thank you.
All right, let's move on.
Okay, we have quite a bit to get through. The next thing that we talked about was congenital heart disease. This came up because in the discussion last meeting in January, there were several conditions that were proposed as for medical management that had to do with conditions, congenital conditions of the cardiovascular system that didn't really have any treatments, and there was a thought
That's page 228.
Thank you.
And I was asked to look to see if there was anything other than office visits that might be needed. This led me to I went a little beyond what you asked me to do. We have 19 covered lines with various congenital heart diseases and their treatments with no guidelines. My suggestion was to combine all 19 of these lines together. These are conditions where the treatment's usually some type of like open heart surgery or invasive procedure. They're not likely to be overused. Sometimes the conditions overlap. People don't follow textbooks. They may have a combination of two congenital heart conditions or something. And this would allow the surgeons to pick and choose what they felt was the best surgical treatments. And that I believe there were 6 or 8 congenital heart conditions that, like dextrocardia, which is a heart that's rotated the wrong way. There's no need to treat that, but if it was part of a bigger spectrum of congenital conditions and they did need to fix it with whatever else they were doing, fine. So that would all be in one code group. Does anyone have an objection to that massive lumping? I don't know why we have 19 congenital heart condition lines, but we do.
I have no objections.
No objection.
And then we went on to ophthalmology. Ophthalmology was broken down into 6 parts because eye specialists are very specialized these days. The first was a general ophthalmology office visit group. So ophthalmologists
Page 231.
Got it. Thank you.
Ophthalmologists do not use standard office visit codes like other primary care, specialty care people would use. They have their own set of codes. So these would be, these conditions would all be in that code grouping where an ophthalmologist could see them. Their office visit codes include some of their basic tests that they do for pretty much standard evaluation of an eye. So there was a whole huge, very, very extensive list in your materials of all the conditions that would be in that group. And UPS didn't flag any of them as needing any further discussion. Then we talked about corneal diseases. The staff recommendation after talking to a corneal expert was to merge our current covered corneal line with some uncovered corneal conditions and kind of make a corneal condition line that would have a series of different conditions and different treatments. Again, there was very little discussion. People thought that seemed to be very reasonable. browtosis, which is a condition where the brow can sometimes sag. It can be cosmetic, but it can also get into the visual fields and cause functional problems. There's
Page 249.
There are standard guidelines about when brow sagging gets to the point where it would affect you. So the proposal is to cover that with that. Actually, it's basically our current guideline, just with technical changes. There again wasn't any discussion there. We looked at eyelid conditions. This is a range of conditions, some of which are just cosmetic, some of which have huge impacts on vision.
Page
Multiple
256.
diagnoses and treatments were proposed with a guideline. There was a lot of discussion. This was tabled for a further input from the expert I consulted and inviting him to a future meeting to answer questions. If anyone here has any other concerns about the eyelid conditions, I'm happy to take any input you have. When I talk to our expert, I'm happy to bring up any additional questions. It was Dr. Ashraf from OHSU. Yeah, so basically just general questions, and then just, so if there's no questions from this group, you'll be seeing that again at a future meeting. Similarly, lacrimal duct disorders, which are conditions of the gland that produces tears and the duct that takes tears to the eye. We currently only cover treatment for children. This would have expanded coverage for adults who have, for example, chronic infection of that gland, blockages of the tear duct that's leading to infection or other problems. Folks this morning had some concerns, particularly for the proposed coverage of epiphoria, which is excessive tearing, that might not need, that might be just more annoying rather than actually a medical issue that would need to be addressed with a procedure. So I was, that particular question was asked to look at maybe perhaps really narrowing down like specific criteria for when chronic tearing should be covered. And then there was some other, the guideline that was proposed was just for the probing, which is the taking a device to kind of try to open the duct. We also proposed in this coverage of several surgeries, but they're not in the guidelines. So I was instructed to kind of write into the guideline, you know, probing should be done for the following reasons. And then like, when would you move on to the next step, which would be surgery? I'm going to ask the surgeon that, and hopefully he can come to another meeting and answer any questions. Anybody have any other questions or issues or things they would like me to discuss with him when I talk to him about lacrimal ducts?
We're just adding this as additional coverage for adults.
And there would be additional coverage for children.
Adults and children.
Says these services are.
So children have to have purulent infections to be covered, so this would actually expand that a little bit.
It'd be EPSDT no matter what.
And they're EPSDT no matter what.
Okay.
And just for those who may not be aware, EPSDT requires an individual review before denying a service. So that's
based on medical assessment.
Based on medical assessment. So it's a high, you know, it's a high bar to deny something like that.
Okay.
Although we typically don't cover this in children under the age of 12 months because it can be physiologic and self-resolve. So that also, but that would be approved on a case-by-case basis as well.
And that's part of the medical assessment. It's constantly, or it's not appropriate or not standard of care. So in catching too.
But if anyone has any additional, like I said, I will be getting in touch with our ocular plastic surgery specialist to loop him in. Then the next set of things we looked at was colorectal surgery, and staff apologizes, but there appeared to be an issue with this not being released in the public packet, and so we couldn't vote on it. There wasn't a lot of issues that the group this morning had. The first bit was basically, there are basically three large categories of colorectal conditions that are currently uncovered. One is hemorrhoids, which we actually moved to coverage in the fall. And so we would need to just do some technical changes for the coverage you already have approved to make it a part of the BUP. There would be a code grouping instead of a line, and and guidelines would be modified. So very minor issues there. Fecal incontinence is the second. This is when stool is kind of passed uncontrollably. The staff proposal is to cover like the major intervention, which would be like colostomy, which is not something that it would be overutilized. It's usually done only when someone has like a cubitus ulcer or some other major complication of something, and you can't keep it stool free, so it's getting infected. So that coverage actually already pairs, but we would just call out that it is covered when needed. And then sphincteroplasty, there was an evidence review done that doesn't show that it's terribly effective. It's not really covered by private payers, so calling out that we don't cover that. And then sacral nerve stimulation is currently not covered with a guideline. The evidence does show it is effective. So essentially the current guideline would become the criteria, which was probably always there for approval by exception, but it would now be a little bit more straightforward. There wasn't a lot of discussion about this one either. Happy to entertain any questions since we can't approve it. And then the last kind of category of colorectal issues that we have is anal fissures. Anal fissures come in two main categories.
Page 271.
Acute anal fissures are little tears in the delicate skin around the anal opening. They typically happen after a hard bowel movement or diarrhea. They almost always self-resolve with a little bit of time. Maybe if they kind of occur more regularly, getting someone to have more fiber and water in their diet, sitz bath, etc. They are currently on a non-covered line, but the medical visit to diagnose them, the fiber supplement, if that's what was recommended, those types of things are already being covered. So, I consulted the two colorectal surgeons that I've been working with. Neither one felt that there was any other treatment than that needed. So the suggestion was just to cover that by combining, you'll see, I'm going on to the other part, the chronic anal fissure. This is when that little tear or opening is present for more than 6 weeks. This can happen for a variety of reasons. There can be nerve damage in the area. There can be an underlying functional or physical issue. It's typically treated initially with conservative measures, the same things as the acute. So having someone have more fiber and water in their diet, not strain when they stool, et cetera, et cetera. If that's not effective, Botox injections can be effective. We currently have them paired and in the Botox guideline, but it's a non-funded condition, so that would only be covered under exception. There are also various surgeries that could be used if it gets to the point where these kinds of things are needed. We have a guideline written about when we do cover surgery for chronic anal fissure, but again, it's on a non-funded line. So the staff proposal was to add coverage effective this year for both acute and chronic anal fissures. We would add them to the anal fistula line, which is 391, so it's covered. There would just be three diagnosis codes there. We would add the Botox code and add a couple guidelines. So essentially, acute anal fissures would still have the medical visit and the medications, or not medication, sort of the, whatever fiber, if you gave it as a prescription. And then the chronic would have surgery if it progresses despite conservative treatment, which is defined, or the presence of pectinosis or fissures that have recur 3 or more times. And then also we would cover chemodenervation, which is the medical term for Botox injection. The discussion this morning, and then strike the 2 lines, the 2 unfunded lines, and then delete them for the next manual review. There was discussion this morning that what the surgeons had recommended in the guideline included topical medications such as nitroglycerin or topical calcium channel blockers. It was unclear to the members here this morning whether those are actually available. So I was asked to talk to our pharmacy and therapeutic colleagues specifically to ask, can we cover compounded medications because calcium channel blockers are only available in compounded form? And then to check with them what other, is there a topical nitroglycerin that's of the appropriate strength or other topical treatments that we do cover, and work with them to see what is available, and then work with our colorectal colleagues to see how we could modify the guideline to make it, we don't want to require that somebody try something that we don't pay for. So I've been tasked to do that piece. Any other concerns or any other things that you want me to work on when I bring, so what I plan to do with the colorectal surgery, since there was really no discussion with the general, kind of the hemorrhoid conversion as well as the fecal incontinence issue, those would come back as consent issues to just be approved after they've been out for appropriate public comment. And then the acute and chronic anal fissures would come back for discussion once we have more information on the medications. And if we find out from PNT that there's wide availability of a variety of medications, I would bring that back as a consent agenda item. Any questions about any of that? Then we talked about sports and orthopedics. The vast majority of conditions that are currently on sort of the non-covered lines with sports orthopedic conditions would be just evaluation of medical management.
Page 308.
Thank you.
There would be a group that would be available to have PT/OT, and then there would be a group that would be available to have PT/OT as well as joint injections. We reviewed all of these diagnoses. There was no questions and no concerns by the group this morning, and they approved as presented. The last topic was podiatry. I was actually asked by the podiatrist to not come to a vote, so we just reviewed it. It's essentially coverage as what we're having now, but adding additional coverage for hammer toes, which are sort of deformed toes, as well as bunions, which are sort of a deformed area around the great toe, with a very strict guideline that would include things like you would need to have a high-risk condition like diabetes or peripheral nerve disease. You would have to have an ulcer or infection in the area of the hammer toe or bunion. You would have to have appropriate pulses showing that you have good blood flow in that area. And
this is for surgery for those things.
Surgery for those things, yes.
Not to get like special shoes and stuff.
Well,
We'll get to that.
That's a different.
We will get to that.
Sorry.
And so, and you have to have conservative therapy first, and it has to cause some significant functional limitations. That was the guideline. There was questions this morning about what about somebody who is has severe functional problems from their bunion, for example, but they are not diabetic or don't have another high-risk condition. Do we want to include them? So I will work on that. We asked that they have conservative therapy in this guideline, including orthotics, modified footwear care, and wound care. However, there is a rule, an Oregon, an OAR about orthotics and footwear that would limit quite a bit, and they're really only cover orthotics if you're diabetic, according to the current rules. So staff have been charged to work with our colleagues who do the DME rules to see if we need to coordinate coverage there at all, or add any coverage for orthotics.
Full transparency. The
Why-
durable medical equipment is an optional Medicaid benefit, so there'll also be a budget assessment.
Yeah, and podiatry itself is an optional medical benefit for.
I have a question. Why was the decision about bunions done the legislature and not by the HERC?
It was not done by the legislature. It's done in administrative rule, which is another arm of the agency. However, we talk to each other and they talk to the budget team, and it's been this way for a very long time. And so we're going to relook at it and see what kind of proposal we can have to best serve our patients based on clinical criteria.
Because
Yeah,
some
just
people,
Just to let you all know next steps, we have a meeting set up. So once this went out for public comment, the Oregon Podiatry Association reached out and wanted to have a discussion on multiple points. So we have set up a meeting with them that will happen in April. And we'll be able to talk to them, get their input as well on your questions and any input they have. And then make a new revised proposal, looping in our DME rural colleagues at the state, and then we'll give you a revised proposal for May. And the podiatrists will be coming in May.
Right.
Okay.
So you have a lot of stuff tabled that will be coming back.
Okay, so is that,
Yep.
is that whole thing?
Yes.
Okay, so we have to go back and vote on everything.
Everything except cervicogenic headache.
Okay,
And all the tabled things.
okay, so that's all the rest of the meeting we have to vote on. Does anybody want to move to approve everything else?
Did you discuss GWA? Let's do.
That's a separate report.
That's a separate report. Okay, I'm
Let's
sorry.
yes.
So
Settle
just what
down,
you,
Jason.
the rest of the meeting so far.
Nice.
All right, are you moving to Linnea? Awesome, okay. Who wants to second?
I'll second.
Great. All right, thank you. Jessica, can you call the roll, please?
I will. Mark Buckles,
I approve.
Mike Collins,
Yes.
Stacy Geisler,
Approve.
Max Kaiser,
Aye.
Lisa Kouzes,
Hi.
Linnea Lindsay,
Aye.
Larry Lyon,
Yes.
Chris Pinzon,
Approve.
Katie Shable,
Approve.
Devin Consagara.
Yes, approved.
It's unanimous or unanimous.
All right,
Yay.
that was much easier. Okay.
So that was VBS this morning. Our evidence-based guidelines subcommittee met last month. And we have charged them with some of the benefit update project as well, just to spread the wealth and to get more input. They approved the proposal for gynecology, and so this did not go to VBS because EBGS has already looked at it, so it's coming directly to you. The proposed changes would add coverage for polyps of the vulva and vagina and vulvar dysplasia and cysts. This would help to diagnose more serious conditions, and this was recommended when we met with experts. We currently have a guideline for hysterectomy for chronic pelvic pain and dysmenorrhea, which is pain with periods. These are unfunded conditions. The proposal is to cover these, and actually the guidelines for these two are exactly the same, except for like the word dysmenorrhea or the word chronic pelvic pain. So the staff is proposing having a single guideline for both. And we'll do the minimal modifications that we do to make them part of the BUP process. Our gynecology experts felt that they felt that perhaps that these are being done with different diagnoses. They didn't really feel that it would be used more. I'm not sure if how accurate that statement is. There may be an increase in utilization of hysterectomy if we do this. And then several different gynecologic issues will be office. Thank you. So the staff recommendation is to create a code group for benign neoplasms and conditions of the external female genital organs with the ICD-10 code, CPT codes, from both the covered line or cysts of Bartholin glands and vulva, as well as a whole bunch of other things that are in the table, and add a couple of the CPT code for destruction of vaginal lesions there. We would also create a code grouping for pelvic pain and dysmenorrhea that would include the diagnoses from chronic pelvic pain and dyspareunia, as well as the line for dysmenorrhea. Some of the diagnoses that appear on the chronic pelvic pain line actually will end up on just sort of evaluation and management only. You can look through the table if you're interested in which codes they are. And then guideline modifications will basically just be for pelvic congestion syndrome, kind of just rewording the current guideline. It just to make it one sentence and sounding better, but no change in really the intent. And then our chronic pelvic pain dysmenorrhea, kind of a combined guideline. And basically that just required adding the words or dysmenorrhea to the current pelvic pain guideline. The one thing that the gynecology folks wanted changed was we currently have a requirement for non-malignant cervical pathology of cervix is present. They wanted that changed to up-to-date cervical cancer screening. Because they felt like the current one might be represented as you need a current PAP, and that might not be appropriate based on the current. We have now a 5-year cycle for many women. For chronic inflammatory pelvic conditions, that would no longer need to have a guideline saying that it's only on a lower line. And then opportunistic self-injectomy would just have the typical changes. So there's a lot of things that would be evaluation and medical management only. Then several chronic self-injection and oophoreitis. The experts said that should be in the surgical group because pretty much that just shows up as a mass. They go in to take it out, and that's their final diagnosis. And then subarachnoid glands, peritoneal adhesions, things like that would be covered. Middle schmerz, dyspareunia, those types of things would be covered from the medical management.
This is Daphne. Is it just me or is no one sharing screen?
Yeah, when the meeting ended, it kicked me out, so but now my internet's crapping out here, so.
Okay.
I think it's feeling like it's 4 o'clock.
Okay.
Yeah.
So,
Yeah, it sounds like there may be some network difficulties, so we know what page we're on. Is everybody able to track?
A bunch of pages.
Yeah, there was a bunch of pages. We're somewhere down in the 340s.
Yeah. Then there's a lot of codes. These were looked at in detail at EPGS, and we have at least one gynecologist on that committee.
Want me to try and share? I'm on 340.
Well, that's kind of the beginning.
well, if everybody is, we're kind of getting past time here, so is everybody able to kind of following along? And then what do we, is this something we have to vote?
Yes.
Mhm.
Okay.
If you all feel that's appropriate.
Can I ask questions?
Yes, of course we can ask questions.
So what, for all the lesions, excisions, cystis, what are we doing now? Because if they're truly diagnostic, they should be covered now. And some of those things are not necessarily symptomatic, and I don't have a lot of gynecologists beating down my door saying we're missing diagnoses for these. So what are the things that we're not helping diagnose that are more serious conditions?
What problem are we trying to fix, you mean?
Yeah, so
Of the ones that they wanted, currently we only cover excision of Bartholin gland cysts if they're infected. So
Yeah.
allow like just general excision, polyp of the vulva.
like why would they want to cut one out that's not infected? Just because there's a fair amount of it that can be irritated. I think all down with waiting. What is the benefit of cutting them out when they're not infected?
If you feel that should be evaluation of medical management instead, that would
I
be.
mean, I think most of the, I don't think we have a blanket area of the body, we would just say like, hey, lumps and bumps, we cut off. Right, there needs to be some sort of symptom or some concern or, so I just don't quite understand where this is coming from, which is why I'm asking like, what serious conditions are they worried about?
Well, but then we have things like ulceration of the
missing?
vagina and vulva, which we don't cover right now, but I could see that you would want to biopsy that to see if it's not
Right,
like
then
a
that's diagnostic.
squamous cell cancer or.
Yeah, so I guess I just don't follow, and it seems like that is so broad, we'd be covering a lot of things that are
So
asymptomatic.
those would just be evaluation of medical management, which is what they are now.
Right, I mean, adding this guideline though, it just seems overly broad to me and I don't understand what problem we're solving.
And
It says here, so these procedures would help diagnose more serious conditions and are recommended by experts, so.
I know, that's why I'm asking what serious conditions and what are they recommend?
Well, I don't know if that means the equivalent of an excisional biopsy. Is this what that is?
But that should be covered, diagnostic procedures are covered. We don't need a guideline up to tell us that they already are.
We don't have a guideline.
No, we shouldn't, right? Because any biopsy code should be diagnostic.
Right, so the only things that they have recommended, so there are many things that would end up on evaluation of medical management, which would include anything diagnostic, and that's what a lot of these end up.
So you're allowing that evaluation of this condition. And then, so we would have that at least E&M code for that. And then when they take it out for biopsy, that would apply under the diagnostic phase, that's already.
The CPT should be diagnostic. We are statutorily required to cover diagnostic interventions before we have a diagnosis, whether they think it's funded or not.
So the only things that they specifically called out that they wanted would be a vulvar cyst or a polyp of the vulva. And I don't recall the conversation about why they felt those should be called out separately.
Yeah, I think I need more information.
Do you wanna table that specific thing?
Yeah.
So vulvar cyst, polyp of the vulva, dysplasia of the vulva, unspecified, was on one of these lines, probably because it was unspecified. All of the other dysplasia of the vulvas is on precancerous line.
Wouldn't have dysplasia until you already do biopsy unless you guess.
It's like current vulva.
I guess I just don't get it. I just don't get it.
I'm highlighting a lot of these
like more
things
clarity
to
about
look at. Okay, so
necessity.
okay, so Max, let me just go back. Things that are recommended for more than evaluation of medical management would be some chronic things of so chronic selphingitis, oophoresis, chronic inflammatory disease of the uterus, chronic parametritis. They wanted those covered in the surgical group because they can't make that diagnosis without surgery.
Right, those you go after, so.
And they have to code what they feel is most appropriate after surgery, I guess.
Yeah.
Anyway, so
yeah.
I think that made sense.
Yep.
Female pelvic peritoneal adhesions, they also wanted in the surgical group, again, probably because they encounter that in surgery.
I don't know why, yeah, because there are a lot of theoretical exploratory / therapeutic surgeries for adhesions, and the data is not great because you can create more adhesions when you do a surgery.
Okay. Cyst of the Bartholin gland, you want that?
I mean, it's infected, sure, but I don't.
There are
I'm not
other
following
codes
that.
for infected.
Right, that's why I'm not following.
I will look at that. Again, did I just put this in twice? I did, yeah, so there's, the adhesions got in here twice somehow. Polyp of the vulva, dysplasia of the vulva unspecified. And I think that was just because ICD-10 runs the gamut. It always, everything ends up with an unspecified at the end of it. So it may be that one was just an outside of its code group and I wanted to put it back together.
I mean, the polyp, I think, are questions in and of itself too. Again, if it's diagnostic, you don't need that.
Vulvar cyst, I will look at. And then primary dysmenorrhea, secondary dysmenorrhea, other specific conditions associated with the female genital organs and menstrual cycle, they wanted on the surgical line for hysterectomy, as well as post-endometrial ablation syndrome.
So that's a different thing, that's treating symptomatic disease.
I have questions about the other guideline too, so we're not there yet. Yeah. Well, we can jump to that.
Marsupialization of Bartholin gland cyst is on, they wanted that to match Bartholin gland, so I'll highlight that.
Yeah.
Same with excision of vaginal cyst or tumor. Well, that seems like it would be diagnostic.
Or if they know it's benign, then it's, it's like a lipoma. We get lots of requests to take out lipomas that we don't cover.
And then, like they pointed, we had a couple of uterine suspension procedures on our chronic pelvic disease line. Those are actually done for uterine prolapse.
Yeah.
So the suggestion was to move them to the uterine prolapse line. Hysteroplasty, And hysteroscopy would be in the benign neoplasms and wounds. No? You want me to look at those?
Let's go.
Can you speak up, Max?
Yeah, what are they, one of them was the scope, right? Was the other one?
Hysteroscopy with resection of intrauterine septum. The other one was hysteroplasty repair of uterine anomaly Strassman. I can bring you more information about those if you want.
Yeah, that would happen. And we're speeding through.
Any questions about the uterine suspension being put in with? And then there's fluoroscopy, plastic repair of uterine cervix. I thought that wouldn't be medically necessary.
I don't know what that is.
I can find out a definition.
I can trust you if you said it's not necessary.
Yeah.
Okay, yeah, that was.
Okay, so we have a list of things that we're gonna come back to.
Yeah, and then did you have a question about the guideline or concern?
Yeah, the dysmenorrhea and.
Okay, because it is that's our current guideline, they're just not covered.
It's not funded, yeah.
Yeah.
So I don't think I was around when that was made.
They're ancient.
Yeah, I'm wondering where those came from, how evidence-based they are, what was the outcome data, was there the population that much, et cetera. Is this from a society guideline or was this? Like it makes sense if somebody told me to create one, like I would write it like that. But that's me just going on what makes sense.
I think, so there are 5, 6, I mean, there's a whole series of hysterectomy guidelines. One for endometriosis, one for dysfunctional uterine bleeding.
You're talking about our guideline?
Yeah.
Oh, yeah, endo and adeno are kind of thing.
Yeah,
Yeah.
and they're all essentially the same as this, except for I don't think they have the MRI for adenomyosis, but the rest of it is essentially the same.
This one has a lot more because it's not really got a whole bunch of other pieces for it.
Right, but even some of the other ones have exactly the same, like and some of them like
Well, this one has the GI, the effects. I think depending on it, slightly longer for the medical treatment, the GRTs, all that, and the psychosocial one's not.
So I cannot tell you where this came from or where it originally was.
I mean, that would be my only concern because surgery for pelvic pain is not incredibly efficacious. I think if you ask surgeons, they say, hey, nobody ever comes back, but if you went to them for surgery and you got it, why would you go back? Right, so I'm not sure that's like a great population to ask, is this an effective surgery?
So would you like me to look at the evidence of surgery for chronic pelvic pain and dysmenorrhea?
I mean, if we're supposed to make evidence-based guidance, I'd like to know at least where it comes from. Again, like this makes total sense to me, right? If you told me to come up with it, this seems like a very logical guideline, but if I don't know what it's based on, and even with this, I don't know it's efficacious. It kind of has, it's a really complicated population, which is why this guideline is kind of so extensive.
Right, and they're not covered now, and I think a lot of that reason for it was a lot of concern about chronic pelvic pain. Are we making it worse by taking out doing a major surgery or treating it?
Such significant effects surgery.
So and this was a BUP topic, so again, I did not do an evidence review, so I have.
No, I was wondering, like, do you know our case? Because we've had it, right?
We've had it for.
Okay, that answers my question.
Yeah.
So in other words, I mean, I think a lot of us are gonna be kind of flying blind on this, but in other words, this was not covered before, and the thought was it may have just fallen below the line because of the BUP process, things that might have been indicated but fell below the line before now need to be reviewed and brought back up.
So everything has to be reviewed.
Right.
These, I don't know why these fell so far below the line, whether it was because the effectiveness of the surgery was considered to be so minimal, whether the condition was felt to not be significant enough on its impact on a person that it needed to be addressed. I mean, these are the reasons we put things low.
Right. Right, and so Max is arguing, I think reasonably, that elevating it to medically necessary status would require some clarification as to
and
we
will have to cover dysmenorrhea but it's
Right.
effectively treated with NSAIDs and birth control pills
Right.
and
So I want to make sure we do a big
marinas,
surgery tactic for.
Yeah, right.
yeah, so,
fair
so
enough.
we could put it on the medical visit only line where you would get all the medications and then IUD put in if you wanted it, whatever.
I think there's a
That's why I
subpopulation.
flagged it, I will
Yeah.
look at the evidence for effectiveness.
I think there's a subpopulation.
As we do this, is there a reason to consider combining all those hysterectomy guideline notes, or is the rest of it working fine?
I think it's a pretty different population between those that have.
So there's
just straight endometriosis, adenomyosis, and this.
There's
Yeah,
clear
these are
indications that are
different
not
populations.
controversial.
Yeah,
Right,
and
you
we
can
cover it
see
for
there's some
cervical
clinical
cancer,
evidence of
uterine
those.
cancer, I mean, there's.
Yeah, this one's more a pain diagnosis, it's
Okay.
harder to pin down.
Well,
That's why it's so.
Okay, so since that's both of these things, the polyps and the cysts, and then
There's a lot in there that you
hysterectomy,
want me to look at.
So in other words, there's nothing left to vote on.
It's complicated.
Let's bring the whole topic back.
Okay, so there's nothing left to vote on.
We'll probably take it through EGS.
Yeah, it sounds like this is actually, you'll have to kind of,
Yeah.
Sorry.
Not, well, it did not go as a coverage guidance, it went in this form.
And this is the
And
first one they saw.
This is the first topic like this they've ever done, and so I
okay.
think it bears a second
I mean, this sounds fair. I mean, right, you're asking whether for chronic pelvic pain, this is actually efficacious, or is it making things worse? I mean, that's the sort of thing that should be kind of debated.
We see it
Looked at.
fairly often requested, and
Yeah.
we end up, because it doesn't fall under those guidelines, that's referred to this guideline,
Okay.
even though it's unbundled.
All right, fair enough. Okay, so
Which is why that guideline note is there.
And we look at it in theory for exceptions, right? I don't think I've ever had anybody that's had this work up either. So
Okay, let's,
I think it'll be used.
it's gonna go to EBGS, and then we're gonna finish up now. There's nothing else to vote on. There's a retreat coming up.
Retreat, April 18th. Watch your emails for location, watch our meeting website, and then our next meeting on May 15th.
Maybe 15th, yes. Okay. That's it. Good job, everyone.
Thank you, everybody.
Thank you.